Okay, welcome to the last meeting of our first year as a board. I think it's a pretty monumental day on a number of levels, so really excited to sort of dig in. I know we'll do roll in a moment, but we're hoping David, we expect him, and then Sandra, who I think will be joining in sort of listening mode mostly by Zoom. There's David, perfect. Great. She wasn't able to make it up suddenly today, so we will survive without her, but look forward to getting whatever feedback we can from her. So with that, let's turn it to our LRI team to do roll and get us started.
Wonderful. Good morning. Secretary Dr. Mark Galley.
Present.
Dr. David Carlisle.
Just present.
Dr. Sandra Hernandez. Richard Kroenig.
Present.
Ian Lewis.
Present.
Elizabeth Mitchell. Is that microphone working okay?
Present.
There you go. Thank you. Dr. Richard Pan.
Present.
Don Molds. 7 present, 1 absent.
Perfect. So as we have not a lot of items per se, but a lot of conversation to have on those items. So Elizabeth, I'll turn it to you. Give us a quick update on how things are at HCI and OCA and some of the things that have happened since we last met.
Thank you very much, Dr. Galley. So first, we'll just take a quick look at the, good morning, everyone. Welcome to our December OCA board meeting. We'll take a look at our agenda for today. As Dr. Galley noted, we don't have a lot of items, but we anticipate a rich discussion. We will be talking about the advisory committee. So our advisory committee members, half of them are serving a 1-year term and half a 2-year term. So even though it may feel to you, as it does to me, that you all just appointed the advisory committee, we will be discussing a process for taking nominations in the spring and potentially having a new group of committee members to assist with that. And then, as you can see, we have 3 informational items. We're very pleased that our cost and market impact review regulations were posted yesterday, and Sheila Tatayan will give us an update on that. We also will be talking about the THCE data collection regulations, which have been posted, and then getting into the meat of the spending target methodology and statewide spending target value with a preliminary staff recommendation on the methodology. And in each instance, we'll be sharing feedback from our advisory committee. So that is our agenda for today. In terms of providing some HCI program updates, wanted to start with some updates about our healthcare payments data program, or HPD, given its important synergies with OCA. So HPD program is in the process of finalizing our a visualization for this year. The third cost visualization focused on pharmaceutical costs. So we hope that will go live in early January, adding to the existing suite of public HPD public reporting with our HPD snapshot and HPD measures. Our HPD advisory committee focused its fall meeting on public reporting for 2024, and our 2024 priorities include reporting on social drivers of health, additional pharmaceutical data reporting, and then some reporting on hospital spending. We're also looking at working alongside OCA on the framework for non-claims data collection. Our data access and release regulations for the HPD program will shortly be re-released for a second public comment period, and then we'll be working in the spring on starting to collect requests for HPD data. So those are our HPD updates. And then I wanted to spend some time letting you know about a new program HCI is rolling out in 2024. We will be taking over enforcement of the Hospital Fair Billing Act, which was previously under the purview of the California Department of Public Health. Since 2006, hospitals have been required to offer uninsured and underinsured low and moderate income patients charity care or discounted payment capped at Medicare or Medi-Cal rates. In addition to those caps on what uninsured and underinsured consumers can be charged, there are limits on when hospital bills can be sent to collections, and hospitals have to have clear written charity care and discount care policies, which we at HCI collect. So we post those policies on our website. And we have expanded authority to review those and also to take complaints from patients for the first time. So starting January 1st, consumers can file a complaint with a hospital bill complaint program on our website directly or by mail. And then our team will review those patient complaints, get additional information from hospitals, and review hospital responses and documentation to determine whether the hospital complied with their own policy and with the law. We do have authority to work with hospitals on corrective action and administrative penalties as necessary. So this program really is a big deal for us at HCI. It's our first public-facing consumer assisting program, and we know hospital bills are a significant problem for consumers. We've certainly heard about that in this committee, and we're pleased to be able to assist those consumers. And then last, as Dr. Galley noted, with this being our last meeting in 2023, I am going to take a moment of personal privilege just to reflect a little bit on what we've accomplished as an office and as a board together in the last year. So 1 year ago today, OCA had 2 staff members. We had hired Vishal Pagani in October, and he in turn hired his 3 assistant deputies. Today is Sheila Tatayan's 1-year anniversary with the office. So we had a staff of 2. In January, we added CJ Howard and Megan Brubaker and Jonathan Chavez, who have done such an exceptional job with these meetings and so many logistics. And then we hired Margaretta Brandt in February. And then Sheila and Margaretta and CJ set about filling their teams, and we now have a OCA staff of 30 people. So just want to acknowledge that work. I believe 1 year ago today, Ian Lewis was our only appointed board member. And of course, we knew we'd have the benefit of Dr. Galley and Don Molds in their positions as members. But then in early 2023, we got these other wonderful appointments and had our first board meeting in March. And it truly is hard to imagine 8 more knowledgeable, qualified, dedicated people. So it's just been tremendous to work alongside this board in partnership. So we appreciate your guidance and your partnership and your work for the people of California. So did want to note that. I'd also like to congratulate the OCA staff for running such effective board and advisory committee meetings, a tremendous amount of stakeholder engagement, which is so important to this work. So we have technical work groups, we have engaged with other states, we've engaged collaboratively with our sibling departments and had many, many meetings with all of you. So thank you to those of you who have submitted comments to us, who have come to our technical work groups, who have met with us, who've reached out. So our work is better because of your input, and we very much appreciate it. We've launched our work to set the APM standards and the primary care thresholds. Very exciting and important work. And just yesterday, we finalized the CMIR regulations. At the same time that Sheila's team has been doing those regulations, they're also building the infrastructure to support that important work so that we have the portal ready to accept the notices on January 1st. And then, of course, we've worked hard together to develop the approach on the total healthcare expenditure data collection. And now today, we'll be making, again, a preliminary staff recommendation of a spending growth target methodology for the board's consideration. So I think not bad for year 1 of the Office of Healthcare Affordability. So again, very much thanks to all of you stakeholders who have helped create this office, given us so much input, and particularly to the consumers who have come forward to talk about their experiences and reminded us why this work is so important. So with that, I will turn it over to Deputy Director Vishal Pagani.
Thank you, Director. Before moving on to the slides, I wanted to provide an update on the Centers for Medicare and Medicaid Services new report on 2022 healthcare spending. This just came out a few days ago, so we're still reviewing it. But we do want to share a few highlights. The report shows that healthcare spending in the U.S. grew 4.1% from 2021. Reaching $4.5 trillion in 2022. which is a faster rate of growth than in 2021, but slower than 2020. The report also shows that the rate of growth has become more consistent with the pre-pandemic average annual growth rate of 4.4%. Other findings include a determination that the health share of GDP returned to a nearly pre-pandemic level in the roughly 17% share of GDP in 2022. Although these results were partly influenced by economy-wide inflation. And then lastly, there's the numbers on the share of the population that's insured. This reached 92%, which is a historic high, as private health insurance and Medicaid enrollment continued to experience strong growth. Next, I'll provide some brief highlights from the small business majority listening session that took place November 30th. Small business majority invited OCA staff and board members to participate in the listening session. The small business owners who attended the listening session expressed concern with high healthcare costs caused by many of their employees to choose to work less hours to maintain their Medi-Cal eligibility. Small business owners who offered healthcare find it difficult to pay a higher percentage of the costs for their employees and have sacrificed investments to expand their business and foregone other business opportunities as a result of the high cost of healthcare. The attendees also proposed clarifying the definition of small business into subcategories. For example, designating small businesses under 500 employees, under 250 employees, and under 100 employees. Although OCA doesn't have the authority to enact these changes, we found that interesting to listen to. And now I'd like to turn over to board member David Carlisle, who attended this listening session, and if he had any additional comments to add.
Well, thank you, Vishal. And I thought that the session was very illuminating. It was stunning to hear about people, business owners, having trouble navigating waters that they were just not prepared or trained to navigate. I did have one pleasant moment when I got to say hello directly to somebody I consider a celebrity, who is Mary Sue Milliken, who was on a radio personality. Her show's called Good Food on KCRW in Los Angeles. She was on there as a restaurant owner and was talking about how difficult it was to obtain insurance for employees and how she just wasn't prepared to address that. One comment that I had to respond to directly during the session was, and it was repeated several times, people were saying that under the Covered California Gold Plan, they thought that their access to healthcare was worse than it was when they had regular Medi-Cal. And I asked them to reiterate that, and they did, and they felt that was the case. So that definitely was something that I noted. But the remarks were consistent. These are small business owners that were increasingly challenged by the cost of healthcare in the state of California, and their employees are feeling it, their businesses were feeling it, and they were feeling they were having difficulty in our marketplace. So it was a very, very illuminating, informative session. So thank you very much.
Did they say what was different about the Gold Plan experience and their Medicaid experience?
Yes, actually, they said that the issue was having trouble finding providers under the Gold Plans. And they found, they said that there was more time to service under Medi-Cal, but more provider availability under Medi-Cal. And so they were willing to sacrifice the time to service for provider availability, and they were frustrated trying to identify providers under the Covered California Gold Plans. And these plans were typically PPO type arrangements or HMO arrangements.
Please.
I unfortunately was not able to attend, but I would suggest that these same concerns are actually being experienced by large employers as well. and access is increasingly extremely challenging for commercial, even the largest of employers and public purchasers, particularly for primary care and maternal health. So it is a widespread issue.
No, I appreciate those observations. I also have been noting the increasing reports of basically, well, they call them shortages of nurses, physicians, and others. In fact, I've been doing some work with some folks in the nursing workforce. But what we're seeing overall is frankly moral injury and burnout, and people leaving if they can. And I don't know how many calls I get from physicians who say, hey, is there something else I can do? When I'm in clinical work, I spend most of my time doing administrative stuff, right? We already know studies have shown primary care doctors only spend 28% of their time doing clinical work. Only 28% of the time. The rest is admin stuff. We can double our primary care workforce if we simply allow them to spend half their time doing clinical work. So we really need to look at this overhead problem because it's burning people out. The prior authorization issues where basically patients are put on hold until insurance companies finally sign off on even some of the most minor things that are consistent with quality improvement guidelines and so forth, just gumming up the works all the time. This is frustrating. And then, of course, we have COVID, right? And COVID's not over yet, right? And it's out there, and we are already seeing the hospitalization rates going up again. So hopefully we will not have overpacked hospitals again. But the moralization we're hearing in the healthcare workforce is and so I'm not surprised. People are saying I can't find doctors, hospitals can't find nurses, et cetera. And it's not a pipeline problem because people are leaving. And we need to figure out, and so we can't create an environment where we push more people out because we don't have enough, where people are already having trouble finding someone to take care of them.
So I'll now provide an overview of OCA's 2024 meeting calendar. So we put this calendar together. And in red, you'll see the Healthcare Affordability Board meetings, and in blue are the Healthcare Affordability Advisory Committee meetings. We do have a monthly cadence for the board meetings, and we'll always kind of make sure that, these dates could be subject to change. So what we do want to make sure that we're using your time appropriately. So we will always be assessing whether it makes sense to have a monthly meeting. But this is kind of what we're planning for the upcoming 2024 calendar year. And this is up on our website, and this calendar is a handy kind of resource guide for you all. And then on the next slide, just as I do at every meeting, just reminding the board and the public about our slide formatting key. In yellow, we'll show areas for which the office or OCA has decision-making authority, and then green is decision-making for the board. And then that's all for my updates. I'll turn it back over to the chair.
Okay. So now I think we're at the place where we approve our last meeting minutes.
Let's do public comment on the executive updates.
Before, yes, public comment, sorry.
All right, we'll now recognize members of the public for comment on agenda item 2. Please reserve comments on other items for the general public comment period. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in this room may line up at the podium. Those attending virtually who want to comment should click the raise hand button. If you are dialing into this meeting and you would like to provide public comment, we ask that you submit your comments via email at oca@hchi.ca.gov, or please join this meeting online. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the Healthcare Affordability Board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda, except to place the matter on a future meeting agenda. I will start with the individual at the podium. Please go ahead.
Beth Capel on behalf of Health Access, just as one of the co-sponsors of the Hospital Fair Pricing Act, pleased to note the HCI taking over enforcement, which is badly needed, and there's been a real lack of enforcement in the intervening 15 years since we enacted it. My goodness. So we're looking forward to this. Thank you.
Looking virtually, if you'd like to make a comment, please raise your hand, noting we have an estimated 100 virtual attendees at this time. Seeing no hands raised, looking back to individuals in the room, please step to the podium if you'd like to make a comment. Seeing no one in the room or any hands raised online, that concludes public comment on this item.
Okay, now we can move to item 3, Vishal.
So we just have the October meeting minutes. They've been distributed and also include written public comment that we've received since the last meeting.
Okay, board members, any comments on the minutes? Great, a second. Okay, before we vote, any public comment on the minutes?
All right, this opens public comment on the October board meeting minutes. Looking to individuals in the room, please step to the podium. Looking to those attending virtually, please raise your hand. Seeing no hands raised and no one at the podium, that concludes public comment.
Okay, can we take roll?
We're ready for a vote?
Yes.
Secretary Dr. Mark Galley,
Aye.
Dr. David Carlisle,
Aye.
Dr. Sandra Hernandez, absent, Richard Kroenig,
Aye.
Ian Lewis,
Aye.
Elizabeth Mitchell,
Aye.
Dr. Richard Pan,
Aye.
6 ayes, 1 absent.
Okay, so we moved, so moving on to our action items and agenda item 4. Vishal?
So for this one, I'll pass it over to Assistant Deputy Director CJ Howard.
All right, good morning. Just an update on the advisory committee that Elizabeth Landsberg referred to at the top of the hour. It's that time again where we get to renew and revisit our advisory committee membership. As you'll recall, we appointed a advisory committee of 27 members. That was done by way of a subcommittee that worked with staff to review the large number of applications that we received and ultimately come up with the selected member advice on selected membership. And then we had, I think, 2 board meetings in which we adjudicated the final membership. So in those 27 members, we appointed roughly half of them to a 1-year term, and the rest were serving a 2-year term. We did not establish term limits, but just terms, and so some of those members would be eligible for reappointment. And so we would propose that we would open up a solicitation for new membership, running in that from January to March, to reappoint members to a 2-year term, and then we'll get into the cadence of roughly half of the advisory committee would always be up for appointment or reappointment every year. You know, I sat here so that my clicker would work, and now it doesn't want to work. Oh, but it jumped multiple steps forward. If we could go back. There we go. So this is the current membership. We appointed members into groups of payers, hospitals, medical groups, physicians, consumer representatives and advocates, purchasers, healthcare workers, and organized labor. The individuals highlighted in yellow are nearing the end of their one-year term, which would end June 30th of 2024. So they're perhaps not nearing it, but we need to start thinking and planning for July 1 of 2024. So just a refresher. So the advisory committee appointments, so in statute, there are representative groups. So when appointing members to the advisory committee, the board shall aim for broad representation, including at a minimum from representatives of consumer and patient groups, payers, fully integrated delivery systems, hospitals, organized labor, healthcare workers, medical groups, physicians, and purchasers. The advisory committee, in selecting the individuals should show knowledge or expertise in at least one, if not more, of the following: healthcare economics, healthcare delivery, healthcare management, or healthcare finance administration, including payment methodologies, health plan administration and finance, healthcare tech, research and treatment innovations, competition in healthcare markets, primary care, behavioral health, including mental health and substance use disorder services, purchasing or self-funding group health care coverage for employees, enhancing value and affordability of the healthcare coverage, or organized labor that represents healthcare workers. Additionally, the group composition shall consider the expertise of other members and attempt to make appointments so that the composition of members reflects the diversity and expertise of healthcare entities, purchasers, and consumer advocacy groups. And lastly, in making appointments, the appointing committee should take into consideration the state's diversity in culture, race, ethnicity, sexual orientation, gender identity, and geography to reflect California's communities. And appointing authorities shall consider the experience the member has as a patient or caregiver of a patient with a chronic condition requiring ongoing health care, which may include behavioral health care or a disability. So the timeline we're discussing today, the selection process, we would do a solicitation from roughly January through March. March through May, we could go through the selection process as we did last year around this time, or around that time. And then at the June board meeting, we would hope to have final appointments and reappointments. And then the first meeting with the new members would be the September advisory committee in 2024. Lastly, some of the comments that we captured from our last cycle as we were settling on that final slate of 27 individuals, there was comment that the board, in seeking new appointments or reappointments, would want to consider a retirees perspective, perhaps have an emphasis on behavioral health, commercial and nonprofit, small business representative or perspective, rural and frontier representation, potentially academic researchers, and frontline healthcare workers. So staff proposes basically asking if the board again would want to appoint a subcommittee of 2 members to work with staff to review the application process and ultimately review the applications received and work to ultimately create a final slate of proposed appointments and reappointments to the board for 2024.
Okay, let's certainly, Richard, hear some comments, questions.
Yeah, thank you. Having served on it last time, one of the things is in terms of both the solicitation and the information collected, are we looking at addressing some of the challenges we had in trying to sort out, in order to meet the requirements, we didn't collect certain types of information. So I don't know if there are some legal barriers to some of them as well, but I hope that as we're doing the solicitation and also the application, it would be helpful to whoever is appointed to actually have more definitive information to meet some of the things that were discussed. And so we were having to sort it through their application to see what we can draw out from exactly some of the specifics. So so I don't know in terms of the process for this coming year. So that's one. So that's of course for new people when you solicit, and then I assume that you're also going to, for the people who are up, find out whether they want to continue, and then I don't know what kind of information you're going to provide to the committee in terms of subcommittee in terms of, well, I guess attendance, maybe some other metrics as to the people who are up for reappointment, what kind of information that will be solicited, will be provided as well.
All issues that we would want to work with the subcommittee through.
Okay, so that's something that you'd want actually, okay, all right, that's, I wasn't sure in terms of timing because we're December, right, starting January and so forth, so, okay.
I think there's time for us to potentially make some front end changes.
Okay. Yeah. All right. I certainly have some thoughts on that, having been through this once.
Guess it's time for the subcommittee to weigh in, but and I do not want to presume that the people on there currently want to continue.
Yeah.
But I think if there's anything we can do to encourage continuity, we should, particularly for the non-industry representatives who have a steep learning curve. I think we have invested, they have invested
sure,
time,
right.
The staff has invested time, and I think that it's really important to basically capture and benefit from that newly acquired expertise. So if there's, I don't know if you can amend this or if it's a recommendation, but anything we can do to continue some of those, I think would be worthwhile.
I agree.
This motion, I think a really valuable point, and this motion, at least the way I read it, doesn't limit us from, doing exactly that. Other questions, comments from board members on the process that's being? Your mic, yeah.
I think we had talked about trying to get at least one academic and a retiree on this go around. So
yeah,
just reminding folks of that.
Which I would second.
Okay. There was the slide, CJ, you had just a moment ago with some of what I'm going to say are the opportunities to fill some gaps. And certainly we should, maybe you can put that back up, right? These are all worthy places to fortify our experience. Again, if these are gaps and everybody who's terming out wants to reapply and is appointed, then these would probably remain somewhat as gaps. There were people on the list, though, that I think, at least in some of these areas, can hold weight, not in all, but in some. Okay, Richard, another comment?
Yeah, I mean, it's certainly in any group of people, one can always point out gaps. I also, and I know this is an argument made before, and also now that we have a year's experience, or at least part of a year experience, also groups, you have to think about how large they get, how unwieldy they get as a result of that, potentially, and also what are other opportunities to get that expertise into our deliberations. This advisory committee, as we heard in the very presentation in the very beginning, is not the only body that actually provides input to our board and to the office. So we might want to think about what the role of the advisory committee is and how it functions and how large it is and whether there's other opportunities. And by the way, advisory committee meetings are not closed meetings. They're not, they're public meetings where people can weigh in. So it's in that sense, that doesn't mean absence of someone means there's no input or there's no information being provided to the advisory committee in that regard as well. So I think these are all things we should be looking at. Certainly now that we have a year's experience, I think whoever's on this subcommittee, should probably also be looking at, in addition to the appointees, perhaps also just looking at how well the subcommittee is functioning and what we should be trying to do to enhance its ability to function as it moves forward. So, and I certainly agree with Elizabeth that we've invested in the people we've already appointed. So unless, for example, they missed a lot of meetings and doesn't seem, now that they're on, they're not that interested, we'd probably want to continue most of them, unless they choose not to or have displayed the lack of involvement or interest.
Mm-hmm. Go ahead, Rick.
I know that when we first made the appointments, we were quite reticent, and Richard raised again the question of, how big can the Committee B and still be functional. Sandra and I attended the last meeting of the advisory committee, and I would certainly be interested in comments from others who have attended advisory committee meetings. My sense from the last meeting was, even though there were a lot of people there, it was still quite functional, and that 3 or 4 more people would probably not have tipped it over into dysfunction. So, I mean, I have, I think, less experience with large advisory committees than many of the rest of you, but some experience with them, and I always thought that adding a few more members would not be likely to adversely affect the productivity of the committee.
Just for the sake of the conversation, the subcommittee, I think, once we appoint 2 people, they'll have a chance to see both who's interested in continuing, who applies, and, to your point, I think a strategic decision could be made to expand the group if that's the choice and the recommendation of the subcommittee. But I would offer that feels like a good decision for the subcommittee to make based on sort of feedback with UCJ and how the process goes. Okay, other comments? Go ahead, Elizabeth.
This may be a little out of bounds, but it hasn't stopped me before. When you think about the questions and the refinements to the application, and I agree with Dr. Pan that some additional clarity would help the new committee. I'm wondering if there could be a screening question about whether or not they actually support the idea of affordability, because based on the detailed notes I've read of the meetings, I'm not convinced that that is unanimously supported. So just a thought about an initial filter towards the commitment of the mission.
Thoughts from others, other important points to put in the questionnaire, or comments to Elizabeth's point? Richard, you look like you're ready. Jump in, please.
Well,
yeah.
well, no, I mean, I think that that it's clear what the purpose of the advisory committee is. I mean, we can put questions about exactly how the person will interpret that and so forth, right? I mean, I think that we actually, the purpose of this group is affordability while maintaining quality and equity, right? I mean, that's going back to the original legislation, right? So this group is not just about, drive down healthcare costs by any means possible and no matter what the consequences are, right? And so I think there's a reason for this this office, and we're trying to balance different things with the goal of trying to make healthcare more affordable, but not at any cost, right? So I think that's that's the expectation. But I guess the main thing I wanted to ask is in terms of the appointment itself. So eventually, I guess we'll have to decide on 2 people to serve on this. I know what.
I already have an idea.
Okay.
I think that we're at the point where part of the motion is recommending 2 individuals from this esteemed committee. I would offer, unless others want to jump in, that we ask our former subcommittee to, on the principle of continuity, which I uphold as a clinician, believe it's a very, very good concept. Wonder if it's something that both Richard and Elizabeth would be willing to consider. This was obviously not pre-rehearsed. I just want everybody to know that.
I will say, no one talked to me about it, but yes. I will. I in the interest of continuity, I will accept. The board chooses, yes. Obviously. So.
Could we expand the committee to include the chair?
You cannot. That's the problem. But you can try that again later.
Okay.
You can try that again later. But 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 While Elizabeth's digesting it, what are other people's feedback, and then we can, yeah, Ian.
I would second that motion.
David.
And I would support it,
Okay.
assuming.
I will say it did feel when we first suggested the subcommittee, and personally knowing all of the incoming on this, and it's not just flattery, but you did handle it together, I think, in a very balanced and good way, and we ended up in a good place. So for consideration.
Okay.
Okay. All right. So we want to, there we go, high fives all around. So maybe before we go to public comment, we should get the motion on the table, and then we'll have public comment before the vote. So I think just to establish officially the motion.
I would move board members Pan and Mitchell constitute a subcommittee for advice on the advisory committee.
And I will second that motion.
All right, now let's go to public comment.
All right, we'll now open public comment. For those in the room, please step to the podium. For those attending virtually, please raise your hand. Moving to the individual at the podium in the room.
Beth Capel on behalf of Health Access. As you know, a number of us had qualms about the composition of the advisory committee. And as somebody who's attended all of the meetings, I'd like to say that the balance of safety net providers, behavioral health, people with frontline experience, even if they're no longer frontline workers, and that balancing of size and diversity has worked pretty well. We concur with the discussion about the commitment to affordability, but affordability not at the cost of quality and equity. That the point of this is to get people care, but to try and achieve the triple aim of lower costs, improved outcomes, and improved equity. So trying to bring all the voices together. What I will also say, having conferred with some of the advisory committee members before they were appointed, it was difficult for people to know initially what the expectations were. You know, how many meetings, how much time, how much commitment it would require. And I think as the subcommittee, whoever the brave volunteers are, and the board considers that, that's also something that might be helpful to inform people of now that we have a pattern, since, you know, there have to be reasonable expectations on both sides. Thank you.
Continuing public comment, looking for individuals virtually, looking for raised hands, noting we have roughly 100 virtual attendees. Seeing no hands raised, looking back to individuals in the room, please step to the podium. Seeing no one at the podium in the room and no hands raised virtually, that concludes public comment.
Okay, so let's go to board vote.
Okay, Secretary Dr. Mark Galley,
Aye.
Dr. David Carlisle,
Aye.
Dr. Sandra Hernandez, Richard Kronik,
A grateful aye.
Ian Lewis,
Aye.
Elizabeth Mitchell.
Aye.
We heard an aye. Dr. Richard Pan.
I would just note that the two members are the last ones to vote. Aye.
We have 6 yes, 1 absent.
Okay, I will just say a public preemptive thank you to Elizabeth and Richard. Appreciate it, and look forward to a successful and hopefully pretty smooth, simple process. And agree that encouraging our existing members to continue. I think it's been early. They've earned a lot of sort of understanding of the work, and I think just hearing about the reflected balance is terrific. So you did a great job the first round. Hopefully the second time it's fairly seamless too. Okay. So that was our single action item today. And now we move into some hefty, important informational items. So with that, okay. Sheila's coming. And
All right, the microphone's still on? Yes. Well, good morning. It's nice to be meeting with you again, and happy holidays. I'm Sheila Tatayan. You may remember that. Just pronouncing my last name again for you. So,
And happy 1-year anniversary
happy
on
1 year
the
anniversary.
job.
I didn't even realize that till this morning. I thought, 1 year. And I'm pleased at my 1 year anniversary to announce that our CMIR regulations were approved yesterday and are effective as of yesterday. So I'd like to just talk about how we got here. Oh, I need the clicker. Okay. Let's see if I'm close enough. No success here. Oh, let's go. A little bit of a delay. All right. So I'd like to talk to you about how we got to this point of our approved emergency regulations, and then discuss the language with you and some of the major provisions, and let you know what the advisory committee comments were. So on November 28th, we posted our advance notice of intent to implement the emergency regulations, and they were posted online in accordance with the APA. And then we had to give a 5 working day public notice, which we did, and then we submitted the package on December 8th to the Office of Administrative Law. The Office of Administrative Law then had 10 days to review the package, and that's the procedure for emergency rulemaking. During that time, the public has 5 days to submit comments on the emergency rules, and they must submit their comments to both the Office of Administrative Law and to OCA. So that's what happened by December 13th. And then as of yesterday, OAL issued its decision to approve the regulations. So with our regulations effective and our system being tested right now, we believe very strongly that we will be ready to accept notices on January 1st. So all that remains is the system testing, and we look very good to go on that. I think I need a little help here with the slides. Let's go to the next slide. All right, so a little bit more about how we got here. You may remember that on July 31st, we posted an initial draft of our proposed emergency regulations. At that time, we received 21 written comments. We provided a month-long comment period and received 21 written comment letters. We also, during that time, held a public workshop on August 15th, where people could voice their opinions on the proposed emergency text, and 13 commenters shared their comments at the workshop. That was 187 pages of written comments that were reviewed and considered. And so we took some time to revise the regulations, and then on October 9th, we went out again with a revised draft of the proposed text. At that time, we provided another written comment period of approximately a little over a week. So on October 17th, we received 16 comment letters on the revised draft regulations. And interestingly, that totaled about 183 pages of written comments. So really appreciate the stakeholder engagement and the thoughtful written comments from all of the folks who commented. So after October 9th, and we'll go to the next slide. Is that the next slide? Okay. Okay, great. So after the written comment, we then revised the regulation for the final text that would be submitted to OAL. And as I mentioned, we submitted that to OAL on published it on November 28th, and then submitted it in early December. So during the comment period in which stakeholders had time to comment to the Office of Administrative Law, there were 9 letters submitted. Again, very thoughtful and considered letters. They came from American Physician Group, Anthem Blue Cross, the California Association of Health Plans, California Independent Physician Practice Association, also known as CIPA, the California Hospital Association, the California Medical Association, Health Access California, Kaiser Permanente, and Sutter Health. And several of these commenters enlisted the help of outside law firms to write their letters. So The letters generally restated the prior comments regarding the definitions of healthcare entity, the definition of healthcare services, and the definition of revenue. Also, there were many comments on the thresholds for filing and the circumstances of transactions that would be required to be noticed. Out-of-state entity was also a very big topic of the comments, as was the factors for deciding to conduct a CMIR, confidentiality of documents, and timelines, the timeline of the whole process. So as I say, the letters generally restated the comments, the prior comments, but these letters were framed in the context for the Office of Administrative Law for their review, because they're reviewing for necessity, clarity, consistency, and statutory authority. Next slide, please. So with the final regulation, after it went to OAL, and OAL considered and reviewed the comments it received, considered what's called a finding of emergency, because with our package, we submit something called a finding of emergency. And in the finding of emergency, there's an explanation for each and every provision of the regulation. It's similar to what's called an initial statement of reasons in regular rulemaking, but they just call it a finding of emergency. So that's a good, probably 60-page document explaining each and every provision of the regulation, which is also available in our rulemaking package on our website. So to highlight a few of the areas of the final regulation text, healthcare entity definition. As I mentioned, this was a topic of many comments, and you may remember that initially the first draft defined an MSO as a payer. The second draft took that out, and the second draft also brought in healthcare entities if they were an agent, meaning a parent, affiliate, subsidiary, or other entity acting on behalf of the California entity in California. Looking to see if folks are following this so far. So when we got to the final round of the regulation, this provision has been limited. It's been limited to only parents, affiliates, and subsidiaries that act on behalf of a payer. And I will be going over the exact text of that in a coming slide. So now, other healthcare entities that might be considered as a healthcare entity for purposes of filing a notice would only include those parents, affiliates, or subsidiaries that act on behalf of a payer. Not a provider, not a fully integrated delivery system, only a payer. We removed the mental health professional shortage area as a threshold for filing. That's the third provision of the thresholds, because initially we had indicated mental health and primary health HPSAs, but in running the numbers again, we recalculated and observed that the mental health HPSAs encompassed almost the entire state, so it was just too broad. One of the provisions that was eliminated in the definition of change of control was the transfer of 25% or more of the governance of the management and policies of at least one healthcare entity. We worked through that language many different ways, but agreed with the Office of Administrative Law that it would be hard for submitters to quantify that. So as we learn over time and see the types of changes of control, we may revise at that time. But at this point, it would be hard to say definitively how submitters could quantify what 25% of that is. One of the provisions that was important to the office and a topic of many comments was the ability to toll the timeline when the office is waiting for additional information that it has requested or initial information that it has requested. So when a submitter files a notice of material change, the office does not deem it complete until it satisfies the requirements, meaning that all of the information in the notice, all the questions, and then all the supporting documents have been submitted. That starts the clock. And then if there's additional information, the office will have ability to toll while they're waiting for the entity to provide that information. And that has become a shall instead of a may in the statute. And then finally, what we had in our proposed regulation that went to OAL was a factor that considered whether a healthcare entity could meet the cost target. Their ability to meet the cost target was going to be a consideration in whether to conduct a CMIR and also a consideration in performing the CMIR. But as OAL pointed out, and we anticipated this, that because the healthcare targets aren't set yet, that is a future springing event, not established yet, so it can't be a current criteria. Of course, we're still looking at cost, affordability, and access. It's just the measure of the ability to meet the cost target is considered right now a future event. So again, this could be something that we can revise with our emergency rulemaking authority once the targets are set. Next slide. All right, these are not as, let's say, weighty as the other topics, but other changes that were reflected in the final regulation text. The definition of affiliation was changed to clarify that clinical trials, medical education programs, education or research are excluded from consideration as an affiliation. So they are not required to be noticed. Material change transaction was amended, and it was amended to clarify that transactions in the ordinary course of business, the regular course of business involving day-to-day operations, were also not required to be noticed to the office. And then transaction was amended to clarify that out-of-state transactions could be subject to the notice requirement because the transaction must impact the provision of healthcare services in California. Next slide, please. All right, so here these slides are screenshots of the text so you can see what I was just highlighting for you. This is the section on healthcare entity. So you can see that in particular, number 3, there were deletions, and as I mentioned, only the parent, affiliate, or subsidiary that acts in California on behalf of a payer is considered a healthcare entity as long as they meet 3A and 3B. So that parent, affiliate, or subsidiary acting in California on behalf of a payer has to control, govern, or be financially responsible for the healthcare entity, or be subject to the control, governance, or financial control of the healthcare entity. And then if it's a subsidiary, is acting on behalf of another subsidiary. Next slide, please. And this was what I had highlighted for you on material change transaction. Here's the text. You'll see that subsection 1 excludes transactions that are in the regular course of business. And we're really talking about those day-to-day operation transactions. And then number 2 is really to address corporate restructuring. That would not have to be noticed to us. And then below that is the definition of transaction, and I highlighted the differences for you. Here's the text. And you'll notice that it is a transfer for control, responsibility, or governance that is in whole or in part, because the office has statutory authority to say what is significant. So it's not a requirement that it's a transfer of complete control. It can be in part, and that's specified in the regulation. Next slide. As I mentioned, we eliminated mental health HPSAs, and now the threshold is only for healthcare entities operating in a primary care designated HPSA. And so with our regulation, we had 3 thresholds for filing, and then we had initially in the first draft we had 10. It went down to less than 10, and in the end we retained 8 circumstances. So basically the regulation outlines 8 types of circumstances for material transactions that must be noticed to the office. So This is just a review. This slide just reviews what we had removed in that interim period from the July to the October 9th period. As I said, we had started with more circumstances. We eliminated 2. We did add a 10-year look back. And this aligns with the Federal Trade Commission's merger guidelines, which were also just issued yesterday. So coincidentally and fortuitously, our regulations and the federal merger guidelines were issued on the same day. And then the last provision is about control, responsibility, or governance. And I'm not going to go into these into too much detail right now because I'm actually going to show you the text on the slides. So next slide. Next slide. Next one that has the text. There we go. So these are the circumstances. Excuse me, these are the thresholds. Sorry. So B is the thresholds. We always talk about these as our B thresholds, and there are 3 of them. So a healthcare entity with annual revenue, and we define revenue in the regulation. So with revenue of at least 25 million of California assets or control is the first threshold. And then number 2 is if a healthcare entity has 10 million and they're doing a transaction with an entity that has 25 million, that is the second threshold. And then the third, as I've highlighted several times, is the HIPSA threshold of primary care. Next slide. All right. And these are the circumstances. So we talk about our B thresholds and our C circumstances. And again, there are 8. The first circumstance is if the fair market value of the transaction is 25 million or more, then that transaction must be noticed to the office if the entities meet the B thresholds. For all of these, the entity has to meet the B thresholds. Number 2, the transaction is more likely than not to increase annual California-derived revenue of any of the healthcare entities in the transaction by at least 10 million or more, or 20% or more of California-derived revenue, and this is at normal or stabilized levels of utilization or operation. There were comments about this not having a I would say a threshold amount or a dollar amount, that kind of language in this circumstance. But when you think about how these deals are contemplated, how the agreements are entered into, there's an exchange of material value to get the kind of return that's identified in circumstance number 2. Moving on to number 3. The transaction involves the sale, transfer, lease, exchange, option, or encumbrance of 25 or disposition of 25% or more of the total assets of the entity. Some folks had questions about encumbrance. That is in the statute. The statute uses the word encumber. So we've seen situations where, say, private equity will buy a hospital, lease it back to the hospital, or where a hospital or health entity is encumbered to such a degree that it's problematic and they could later be in financial distress. So encumbrance is a very, very important part of this and called out in statute. Number 4 is the transfer or change in control of responsibility or governance of the submitter. And again, that can be in whole or in part because OCA has statutory authority to say what's significant. So we know that material, significant changes of control, governance, and operations can lead to consolidation and market power. Next slide, please. Number 5 is whether the transaction will result in an entity contracting with payers on behalf of providers, that's consolidated or combined providers, and the transaction is more likely than not to increase the annual California-derived revenue of any of the providers that are in the transaction by either 10 million or more, or 20% or more of the annual California-derived revenue at normal or stabilized levels of utilization or operation. So I want to take a pause on this because there have been quite a few questions about MSOs. And as I mentioned earlier, MSOs cannot be considered a healthcare entity under the statute or regulations. But this particular circumstance, if you read it, you can see that that is the structure and sometimes objective of an MSO. So an entity doing a transaction with a management service organization, for example, contracting with payers on behalf of combined or consolidated providers, and is more likely or not to generate the revenue specified in the regulation, could be a transaction with an MSO that must be noticed to the office. Number 6 relates to the formation of a new healthcare entity, affiliation, partnership, or joint venture. And again, the regulations specify the anticipated, more likely than not, to have 25 million in California-derived annual revenue at normal or stabilized levels of utilization or operation or control. Number 7 on the next slide. Number 7 and number 8 are what we refer to as our serial and roll-up provisions, because we've witnessed over the last decade in particular, and probably the last 2 decades, serial transactions, or what the FTC often refers to as roll-up transactions. So 7 is really about serial, because what will happen sometimes is the same healthcare entities or similar entities will engage in smaller transactions that would fall under the thresholds of the current Hart-Scott-Rodino filings and might fall under other thresholds for review. So these segmented, structured series of transactions often escape review, and then over time, what we see is market power or market dominance. So this is very important for the office to trend, and the statute gives us authority to trend and track. So we included this provision as a circumstance in number 7. And then number 8 is the serial acquisition. Sometimes we refer to this as the Pac-Man, where an entity will continue to acquire more and more of the same type of entity and acquire market dominance, market power, and be in a position to create barriers to entry for other healthcare entities. So those are the 8 circumstances that we often refer to as the C circumstances for transactions that must be noticed to the office if an entity meets both the thresholds in B and their transaction meets any one of the circumstances in C. Next slide, please. All right, so these were again some of the changes that we made over time with the comments and are reflected in the final text. We did remove some duplicative or potentially burdensome filing requirements. The way that our filing works is there's a notice portion and a document portion. So when the submitter will go into the portal, they'll register and they will answer questions. And in answering those questions, they can provide a narrative. And in support of their narrative, they can submit documents. And actually, they'll be required to submit documents. So when you look at our regulation, there is the notice and there's documents to be submitted. On confidentiality, we amended and finalized certain confidentiality provisions to clarify the process for requesting confidentiality and what would be treated as confidential, as well as the process for the office to grant or deny requests for confidentiality. There was one of the comment letters to the Office of Administrative Law that expressed some concern about the Public Records Act, and I would like to note that there is a Public Records Act exemption in the CMIR statute. For expedited review, we also made some revisions. We laid out a process whereby entities can request expedited review if they meet certain circumstances, and we felt that this was important to have this. I will stress that this was not required. The statute said that the office may promulgate regulations to expedite the timelines, and so we did think it was important to provide a means to request expedited review under certain circumstances. And then finally, with our last round of our regulation text, we had included a final section on market failure to note that the office has the authority to conduct a cost and market impact review outside the context of a transaction. However, because that duplicated what was already in statute, it was removed in the final regulation. So the authority is still there, it's just not repeated in the regulation. Next slide, please. And then the timeline. The timeline was revised. There were many, many comments on the overall length of the process, at which the office staff did take seriously because it is also our workload and our timeline. So we did reduce the timeline. The statute requires that the office notify healthcare entities within 60 days of whether a CMIR will be conducted. We put a provision in of a commitment to notify the entities within 45 days of whether they would proceed to a CMIR or not. But if a transaction is going to proceed to CMIR, the office will take the full 60 days likely, because what happens in that situation is if the office determines that a transaction is going to CMIR, there is an appeal process. So when we issue our decision to conduct a CMIR, it will be a written decision with the reasons that we have determined a CMIR is necessary. The entities can then appeal. And so that is why that 60-day statutory timeline is very important for everyone. We clarified the process for tolling the timelines that I had highlighted earlier about when the office is waiting for additional information. And we also shortened the timeline for the release of the final report to 30 days after the public comment period. In our initial draft, that was 45 days. So you can see that we took 15 days off to notify parties of whether they would go to a CMIR. We took another 15 days off from the time to release the final report. Next slide, please. So here are the comments that the advisory committee members made at the advisory committee meeting. And we would like to share those with you as we are required to do so and happy to do so. So there was a question in the earlier round about, again, MSOs and the definition of healthcare entity. And so the commenter noted that we had taken MSOs out. We had taken out that provision defining MSOs as a payer, but yet we essentially retained the structure of MSO when we talked about parents, affiliates, subsidiaries. And yes, we had, but in the final regulation, as I pointed out, only parents, affiliates, subsidiaries of a payer will be considered healthcare entities. And then the second comment was about the in whole or in part, and whether there was any materiality threshold for in part. So you'll notice in our regulations, when you take the time to review them, that there are in part thresholds. You'll notice 25% in many instances that can be in part, and that will apply to the transfer of governance or control or voting rights. This last one on this slide is again about the circumstance C5, the question related to the financial information and whether it would be determined by reference to the current revenue of the organization that is being acquired. And there was concern about manipulation of the revenue that was reported. So to explain how this works, the definition of revenue is based on a 3-year average of California-derived revenue. What we did was for those entities that already report to an existing state regulatory agency that collects their financial information, we try to alleviate the administrative burden by having them report in the same manner. And then for those entities that don't currently report to a state agency, we specified how they should report revenue. So in answer to the advisory committee comments question, it would be an examination of the revenue as it's reported, as defined in statute. And we would also be collecting detailed financial information beyond revenue with our notices, with the notices and the request for documents from the entities. So it will be an overall view of the financial picture of the entities in the transaction. Yes, question?
Thank you. Just hopefully a quick clarification.
Sure.
I understand providers are not exempt. And what I heard you just say was that this applies to payers.
Oh, okay. Only C5. Oh, I see what you're saying. You're saying for this situation, no, everybody's subject to this.
Okay.
Yes.
Just clarify.
Yeah, but so to clarify, C5 is a transaction in and of itself that applies to everyone. My earlier comments were about the definition of healthcare entity. Yeah. Dr. Pan? Oh, I thought you had a question.
Actually, I did. You had mentioned earlier OAL had actually removed the language about 25% control, but then, so I just trying to clarify because you may make reference to 97435E. So OAL removed the 25% threshold, but so this seems a little discrepancy there.
Sure. And perhaps I misspoke inadvertently. The 25%, so we were talking about transfer in whole or in part,
Right.
and the statutory authority for OCA to identify what's materially significant, and that can be part. So the remaining provisions in the final text are the 25% that relate to voting power, supermajority voting rights, and also 25% of assets.
Okay.
Yeah.
Right.
Thresholds.
So those are much more concrete. Okay.
Yes.
Right. But just want to clarify what
Yes.
was removed and what wasn't.
Yes.
Thank you.
So thank you. No, this is helpful in case I did misspeak, which maybe I did. The 25% is laid out in the regulation, and what remains is just for the transfer of control or governance, only the 25% related to voting rights and supermajority voting control.
Okay. Thank you.
All right, next slide, please. The question was, how is California-derived revenue calculated? And I just went through that about how our regulation specifies it's a 3-year average, and we collect it in the same manner that a current state regulatory entity would collect that information based on the type of provider. And then we do lay out for providers who may not, or other entities who may not already report to a regulatory agency, how they should report revenue. One of the members encouraged including non-operating revenue in the definition of revenue. We haven't done that, but when we do collect information on the financial aspects of the entities who are part of the transaction, we should be able to see information about the non-operating revenue as it relates to the provision of healthcare services. There was a comment that some hospitals may report 0 net assets, and they called out one hospital system in particular, and there was another comment that said, I've never heard of that. The question really was about how would this work? And as I said, revenue is defined in the regulation, the reporting of it is defined in the regulation, and we will be collecting overall financial information. So. And then there was a good amount of discussion, probably taking up about 15 minutes about EHR, EMR, and whether those would be considered in the ordinary course of business. And so as that discussion went, it's really a very fact-specific analysis, and the entities will need to just ask themselves, am I renewing this EMR contract, and do the terms of it materially change? questions such as that, because it really is a fact-specific analysis. But we have the opportunity, and this is specified in regulation, for entities to contact us through email or phone to ask questions. You know, as the regulator, we are there to answer those questions. And we do know that now that we've got a regulation passed and our system will be implemented, we will be posting information, frequently asked questions, and some other helpful information for submitters to understand their obligation. There are some great examples on the sites for Massachusetts and for Oregon that have decision trees, and we anticipate our information will look very much like that. Next slide. There was a question about OCA granting confidentiality in perpetuity. When a submitter requests confidentiality, they will have to specify the time frame that they want the office to keep the information confidential. And we will be looking at statute as well, because if they're asking for information that is already publicly available or required by statute to be available, there would not be a grant of confidentiality for that information. And if there's an expired time for that request by statute, we would also follow the law. And then the question of what is OCA doing to prepare for the notices? Well, we are, as you've heard, hiring more and more staff. We've got our regulations approved. We've gone through several rounds of testing of our e-filing portal. So that's what we're doing to get ready. And we're working now on information that will be helpful for the public to comply with our requirements. And then there was a comment about the shortened timelines and whether OCA would have the resources and the ability to be responsive, and in particular in that time frame between public comment and the issuance of the final report. And I do want to say that I do appreciate that timeline, because it noted that when we shaved off those 45 days, it did impose more accelerated work for our office. And so, yes, we are committed to trying to keep that overall time frame reasonable. And yes, we are also committed to allowing time, because our mission is to collect information that is informative to the public. So it's a balance. Next slide. And that is it. Any questions?
I'm sure there will be. Thank you for a thorough presentation and a lot digested in a short period of time. Richard, you're up first.
Thank you so much for your presentation, and I appreciate that the regulations are now in effect. One of the things that I was hoping that could happen is that now that we have the regulations in effect, that we would actually get at least initially a semi-annual report as to how many filings, what triggered the filing, exactly what category they are, and so forth. Because I think that's helpful for us to know, like, are we hitting the right mark? We're getting too many to handle. We're getting, maybe we're not hitting the mark and thresholds are too high, et cetera. So I hope that that's something that the office can do. So, you're starting in January, but maybe semi-annually. So every 6 months, giving us a report like how many got filed, what triggered, what seems to be the reason they got triggered, right? So why did they say that, et cetera, and then the different circumstances, and then the other piece of information would be helpful is how long it takes. Basically how long does it take before you decide whether you do a CMIR or not, and then that timeline, and then of course which one, how many ended up getting a CMIR. So obviously, given the timeline for that, we may not have as much information the first 6 months, but again, some feedback to the board and to the public, frankly, as to how these regulations are working out, so that they're obviously, I think, like any initial work, sometimes there's adjustments that need to be made.
Yes. So with our regulations, as I described, there's a notice portion and then a documents portion. When we receive notice of a material change transaction and we deem that it's complete, we will be posting the notice portion on our website so the public can see that the transaction was noticed, and it will have the general information about the notice. One of the requirements in that notice is for the submitter to specify what circumstances they've met and to describe the transaction. So you'll be able to see on our website why the submitter believed that they had to file and what circumstances they felt they fit into. And I would anticipate that we would regularly update you on the number of transaction notices we receive. And I am very much looking forward to tracking and trending how long they take and the types of transactions, because there could be many transactions that don't take even 45 days to decide whether to do a CMIR or not. In talking to other states about their experience, Massachusetts in particular, because they've been doing this for a decade, we really anticipate that could be the case because they've received many notices that they don't do a CMIR for. I get too close to the mic sometimes.
So again, obviously I appreciate that the actual filings, but in terms of just sort of cumulative data is helpful. So thank you.
It's a good flag. One thing that was helpful for me in the conversation, and just a reminder, in Massachusetts, decade plus experience, can you just say how many, I know it's a smaller state, but how many CMIRs, full CMIRs they've done? And I don't know the denominator in terms of how many transactions have been reported. Could you share that info?
They've had their program for over a decade, and they have done approximately 10 full CMIRs, and they've received over 110 notices in the full decade. So
not that California is going to do exactly that, but just based on that experience, I think your point about the initial notice being somewhat speedy and quick, hopefully we will gain experience over time and have some clarity on what sorts of transactions are more likely to lead to full CMIRs. And as we learn, right, I think the dialogue with the team that I certainly appreciated was, as we learn, we'll be able to make adjustments to some of this. This is, I think, I don't want to call it a starting place, like people expect on when we would make some changes, but I think it's important for these sort of bodies to be iterative and learn from our lessons and others as well across the nation. So I think that commitment is there.
Thank you.
Great. Ian?
Yeah, thanks. I wanted to say when I saw these final changes, there were a couple that tripped me up, but I want to say to you, Sheila, and to the rest of the team here, that the approach and the balance that you struck here really inspired faith in me about how this will be implemented going forward. I mean, just to take off the acting on behalf of payers was a little confusing to me. I do hope that we're going to really go after the full breadth of entities that I think the intent of the law was to scrutinize. I was a little disappointed to see the mental health HIPSAs pulled off as somebody who aspires to the day when much less of the state is a mental health HIPSA. I don't know that as a matter of policy we should exclude a category just because the whole state falls into it, but I understand the approach. And I think you said this, but I wanted to just put a fine point on this, especially for the public, that the pulling out of the market failure and analysis, there's broad latitude, I think, for the director to request analysis where either transactions or the lack of transactions in current market conditions have led to a point where the market simply isn't working for affordability. Is that right?
That's correct. And it was only removed from regulation because it's clearly stated in statute. So
thank you. So thank you.
I do want to clarify the mental health HIPSA. It covers about a third of the state, not the entire state.
Okay. Excuse me. Sorry, Vishal.
Okay. Other comments, questions? It's important. Elizabeth, anything at the moment? David? Don and Rick? No. Okay. I just will say, as we prepare to go to public comment on this, I really appreciate the engagement. I know there was a lot of you in a succinct list listed the key commenters, and it took a lot to respond. And I appreciated through the different iterations how this has evolved, and again, we put our best foot forward, and we're always open to see how it works and stay on top of it. So, your call for periodic summary data of what are we seeing, what's the numbers, what are the categories, I think are going to really help the board, help support you in the work in advancing this forward. So thank you for your leadership and to the folks at this table for getting this done. It was no small feat.
Thank you.
All right. So we're ready to move to public comment.
Okay, we will take public comment at this time. On agenda item 5A, we will start with individuals in the room at the podium and be looking to the virtual participants for raised hands.
Beth Capel on behalf of Health Access. As you heard, we submitted comments not developed by a law firm, instead by myself and other Health Access staff. So we're very much looking forward to the implementation of these regulations and to the oversight that it will bring. We expect we're going to learn a lot of things about a lot of transactions we don't even know about now. So we're very much looking forward to it. We regret shortening the period for OCA to respond to public comment from 30 days to 15. We think there are going to be transactions that are of such significance that a longer period would be appropriate. Two other points, and recognizing that the regulations are final now, we appreciate the clarity that the staff has offered today that things that are otherwise public will remain public, including those subject to the blanket confidentiality provision with respect to contract rates, executive compensation for nonprofits, stock purchase agreements to the extent those are public. It will be important to clarify that for submitters. It is quite common for regulated industries to assert confidentiality of information that is public in other settings. So that's a concern for us going forward. Similarly, if the intent is to look at total revenue, which in the case of facilities is submitted to HCI, it is a little confusing that they're asking for net patient revenue rather than total revenue. There are health systems that have very substantial other sources of revenue beyond patient revenue. So it's just, those are things that we know, as Dr. Galley said, this is the beginning of the process, not the last set, and you have the authority to amend regulations going forward. So we'll look forward to working with you on all this. Thank you.
Thank you. Now we'll turn to members of the public who are participating virtually and look for raised hands. Travis West, we invite you to unmute. Please go ahead.
Hello, my name is Travis West. I'm a regulatory policy specialist with California Nurses Association. First off, thanks for the opportunity to comment. We'd also like to thank OCA for putting together these emergency cost and market impact review standards so quickly. Review of these transactions is incredibly important and much needed, so greatly appreciate OCA's work in getting these done, and glad they've been out there and implemented, and look forward to them going into practice. A couple thoughts also sort of acknowledging that the standards and the regulations have already been implemented, I guess, is we would urge OCA to ensure that covered healthcare facilities do not overly exercise the exclusion of regular course of business and typical in the day-to-day operation of the healthcare entity from CMIR reporting and requirements. We'd also would urge OCA to monitor the emergency rule to ensure that major hospital facility closures rather, and transactions in professional shortage areas aren't inadvertently excluded. Two other things that it seemed to be cleared up in the presentation today. We appreciate the inclusion of series of vertical transactions as material change transactions that are subject to review, and likewise, we appreciate that OCA is continuing to interpret the standard to allow for the conduct of CMIR review without necessarily being tied to a current transaction. So again, we would like to thank OCA for their quick work in putting together this standard, and we're happy to see that it is implemented when we go into practice soon. Thank you.
Thank you. Turning back to the room here, seeing no individuals at the podium. We'll look back at the virtual membership. and no raised hands. So with that, we conclude public comment.
Okay, let me just once again thank the team, the staff for the presentation, and frankly, the hours and hours of work that I know you put in to get to this point. And as always, to the public for their comments, always instructive and helpful to hear. So we are, let's blame it on the chair. We're running 10 minutes ahead. So we will break until 1 for lunch, and we'll see you back here soon. Thank you. Welcome back. Do we have to reestablish quorum? Yes. I think we do. So if we could.
All right, Secretary Dr. Mark Galley.
Present. Good afternoon.
Dr. David Carlisle.
Present.
Dr. Sandra Hernandez. Richard Cronick.
Present.
Ian Lewis.
Present.
Elizabeth Mitchell.
Present.
Dr. Richard Pan.
Present.
Don Molds.
Okay, let's jump in to item 5B. I think again, do we turn it over to Vishal?
Good afternoon. So I'll be covering this item, which is giving an update on our total healthcare expenditure data collection progress. So we've shown this slide with to the board several times. It's our total healthcare expenditures components. The first 3 buckets are claims, non-claims based payments, and then consumer cost sharing. And then we've used an umbrella term above that's called total medical expense to distinguish it between the 4th category, which is health plan administrative costs and profits. And then when we total that up, that'll get us to our statewide total healthcare expenditure measure. So we wanted to provide the board and the public an update on the data sources we're going to be using to measure THCE. Next slide. So in terms of the commercial market data on commercial plans and Medicare Advantage plans, the data that we'll collect is going to be directly from payers. And later this meeting, CJ will be going into the details for some of the data collection regulations for payer submitted data. For Medi-Cal managed care organizations, or MCOs, and Medi-Cal fee-for-service data, we are, the statute lays out that we need to explore other avenues to get data before we go to other sources. So we are closely working with sibling departments, Department of Healthcare Services, to see if there's existing data that they already collect from MCOs that could help fulfill reporting on this market. So we're working with DHCS. So for the first year, we intend to get it from the department, but we'll see if that fulfills OCA's needs. And then our regulations do allow us to get it directly from MCOs if it does not, if after the first year, we just kind of deferred the requirement, and we'll be going over that in more detail later. So this the next row is for Medicare fee-for-service data. So we've already sent a request to CMS, and we have collected Medicare fee-for-service data. And then the last set of categories are other data sources that we intend to collect to be as comprehensive as possible. These include Veterans Affairs, Indian Health Services, and Correctional Healthcare Services. And this is for the baseline report, what we think is feasible that we could get. So it's a combination of payer submitted data, which we need the THC data collection regs for, sibling department coordination, and then federal data sources for these other programs as well. And then I'll go over the admin costs and profits before I take some questions. These are the sources for administrative costs and profits. So our data collection regulations don't request this data for some of these categories because we could already obtain it from existing sources. So for commercial data, we could get administrative cost and profit data for health plans from CISIO or the Center for Consumer Information and Insurance Oversight. This data is also reported to DMHC as well. For self-insured admin costs and profits, that'll be part of the payer submitted data collection process. And then for Medicare Advantage plans, we also would need to get that from CISIO, and we could also get it from DMHC. So those are some of the sources we're going to evaluate and determine which one makes the most sense. And then for Medi-Cal MCOs, as a plan, they would also report to CISIO. And then for those that aren't, a plan, they may be a county organized delivery system. We'll get the data from DHCS, and then also MCOs report directly to DHCS. They have their own set of requirements related to MLR. So this is just to give the board an update on kind of the landscape of data sources that we intend to use to measure total healthcare spending, and I'll turn it back over to the chair if there's any questions.
Okay. David?
Yes, thank you. And I just wanted to come back to the other TME data. How confident are we in terms of getting data from some of these federal sources?
So the ones that we've listed here, we do think we're confident in getting those. There's a source that we could get for California specific data. Some of these may not be the best in terms of, I think for IHS, it'll be more budgeted amounts that are given to support Indian Health Services in California. It may not be the actual expenditures. So we will note that where there are some nuances with the data. And then for correctional healthcare services, CDCR already publicly reports some figures. We're just trying to get a different breakout on an annual level. So we're pretty confident with these three programs. I know there's some other programs like TRICARE, for example. We did do some due diligence in trying to get that data. It doesn't seem fruitful for the baseline report, but we'll continue to kind of see if we could get it in the future. And it had more to do with the way TRICARE couldn't break it out into California specific data.
Yeah.
Thank you. I get the elegance and the rationale for starting with payers data. I guess where I get tripped up is the term total medical expense, because I think there's a substantial amount of money gets shuffled around at the system level, whether it's integrated care organizations and affiliated physician groups and passing through administrative costs, things that you don't typically think of as medical expense that would, in this construct, get categorized as such. Is your thinking that we're going to get that information from the system level provider, information at the provider level when we get there, or how do you think about those pieces?
So if I'm understanding your question, I think I'd want to distinguish between covered benefits, that's services that are delivered for caring for a member, and payments related to that, versus an organization's costs of running their business, and some of it, they're going to have admin. So OCA is not going to look at provider level administrative costs and profits. I know that is an issue that comes up quite a bit, but if there's a healthcare payer, such as a health plan, and there's a claim or a non-claims payment, such as capitation for a member's care, that would be the focus of what we're measuring.
I guess, I mean, I know of at least one very big health plan where, the health plan itself carries costs on behalf of affiliated provider entities. And potentially those affiliated provider entities are carrying costs for the health plan. And I guess I'd just be concerned that we're losing a level of granularity if we're making that this payer versus provider distinction in every case. I mean, and there may not be an answer to this right now. I'm just posing it.
Yeah, before we jump in, I don't know if you want to.
Oh, I think I saw Rick wanted to add something.
Do you want to add on this issue, or?
I mean, we've discussed this before, and particularly in California with delegated models, there is quite a bit of admin that goes on in the medical group level, and at the medical group level. I don't know an easy way of, or even a not easy way of getting at that very well. So I think it's, sort of acknowledging in the baseline report very clearly that, what we're measuring as admin is only one part of admin.
Yeah.
Is, likely the best we can do in the short run. But
we do intend to put that into context, that especially for the non-claims, and if capitation is being used, we don't. It is going to be categorized under OCA as total medical expense, but we know that not all of it's going to be for healthcare delivery. There's going to be some admin costs and profits for the delegated provider. So we would put that into context.
Yeah, I mean, and related, the hospital administrative costs that aren't even around the delegated model, but just, are very high, is a big source of concern, obviously, and not something that, we're planning on capturing in what's in front of us now. And as we're kind of thinking about the future is probably an important piece. Some of that can come out of the annual financial disclosure reports that HCI gets, in another agency. And that actually might be able to bring in a piece of that into the baseline report.
Yeah, I mean, I think it's an important point about partly how the data is currently structured and how the OCA statute calls out admin costs and profits. The health plans are already reporting that to DMHC, and because of the MLR, we can access it. And we don't currently have a structure for capturing either, as Rick says, the hospital admin costs and profits or the medical group physician organization ones. But I hear your point that to call it total medical expenses when it includes the admin costs and profits of perhaps several layers of delegated entities is inexact. We can keep looking at ways to try to get at that down the line.
Yeah, but I think actually on the hospital side, we do have some ways of capturing pieces of that.
With the financial.
Yeah, less so on I think, as far as I'm aware, less good information on the medical group side. Mm-hmm. But at least on the hospital side, there's a lag. So you'd be, maybe a year or more behind where you might, want to be. But it seems like you could bring those data in, and that it would be very useful, even as part of the baseline report. I did have,
does that resonate? I mean, I think this is a good question for the team. Is that something that either we've already planned to do or it makes sense to consider doing?
Go ahead.
Yeah, that's something we could take back. We know that THC or TME is not the full picture, as has been discussed here. So we are looking to see what other data, including the HCI financials, could be used to supplement and explain kind of trends and drivers and spending and just other basic facts so that everything's being put into context.
Okay. Rick, separate point, and then Elizabeth, what can be next?
I wonder also, thank you, Michelle, for the presentation, what your thinking is about a variety of other things that we've discussed in the past, particularly thinking about out-of-plan, out-of-pocket expenditures, mostly on the behavioral health side, although other things as well, and also about, it's an issue we spent a lot of time on early on, which is public health spending, and whether, in the slides here, there's no mention of either of those. Are you thinking that the baseline report would not have anything on either of those, or that the baseline report could include that information?
So for out-of-pocket, out-of-plan spending on mental health or substance use disorder services, we are actively exploring MEPS data, and there's some variables in there that we could use, pull together across a number of years to do an estimate of that spending for consumers. And we hope to get it, if we're successful, it could be included in the baseline report. And if we get some findings in this area, we'll definitely bring it back to the board. And we are spending staff time on that effort. For public health expenditures, that is something early on we did say it's out of scope for now. But as we could staff up and build capacity, we could reconsider it in the future.
Right. I encourage the reconsideration.
Elizabeth.
Yeah, thank you. I just wanted to add a strong +1 to Ian's point about getting the provider data, particularly when we see some of the comment letters saying, the drivers are wages. And I'd love to understand what other options there are amongst the different cost buckets to identify savings, and then also particularly in the out-of-pocket. As Rick said, I think it's really important to have that insight as we monitor affordability.
Richard?
Yeah, I think I recognize that some of this, as I said, I would second the public health opportunity when you staff up. Obviously trying to conjecture as to exactly what people pay out of pocket. Maybe looking at MEPS and others, but it can at least give us but I think it's important when we frame this, right, that we have the caveats need to be in there, right? So that I don't want anyone saying, oh, that's what we spend on. If anyone put something in the press and said, oh, the HCI or Office of Healthcare Affordability said our total medical expenditure, it's like, someone's like, no, that's not what it really, this, you have to understand the caveats. I mean, for example, one of the things, talking about administrative costs, frankly, what we've seen is, basically people pushing medical costs down into practices, right? So, I mean, there is that layer of, plan, then you have the layer to medical group, but, as I mentioned before, primary care doctors, right? There's a couple studies already shown that we spend a fraction of our time doing clinical work. Well, what are we doing with the rest of our time? Well, some of it's documentation, some of it's, let's talk about prior authorization. Prior authorization basically ties up medical practices and requires medical practice staff. Now, is that medical expense or is that really administrative expense that's really been passed down so that it's now being burdened that, and the individual practices are now burdened with that, right? Because essentially now we're the ones who have to hire staff and stuff to do that. Is that a good use of dollars? All right. And is that really medical expenditure or is that really administrative cost, right? And so in this data, it looks like medical costs, but frankly, it's administrative burden. So, if you're talking about the person on the ground trying to take care of patients and they're having to spend more and more of their money
meeting administrative demands from, from their payers, that's not increased medical capacity. That's increased administrative costs, right? So I realize that it's going to be hard to capture, but I think it's important that we at least make some efforts to look at that, encourage researchers to do that, and then and factor that into any into our work. Again, both in opportunities for savings, frankly, as well as as well as basically trying to figure out like how do we make best use of our frankly significant investment in healthcare, health professional education.
Great. Other comments? I'll just sort of echo +1 to a couple of the comments. Obviously, we've talked a lot about the outpatient, the elusiveness of outpatient expenses. And I guess one thing I would ask on behalf of all of us is that we understand it's hard to get today, but it'd be nice to outline the path to be able to get it, right? And I don't know exactly what that means for the team, but putting some brain trust around it, I think would be useful, surveying other states and understanding what might be possible without committing to the capability to do it, but to stand here again, talking about it, understanding that it's a major issue around affordability, right? I mean, people are, whether it's behavioral health in particular or other areas, I think clearly there's some challenges in that space. And then the second piece, just really, I appreciate, Richard, your just sort of articulate sense of the administrative costs. And, we often, even in MLR conversations, it's sort of put in this bucket that is full of a bunch of different things that we should probably disaggregate in some way and try to understand what those pieces are. And then if it's getting pushed down to practices, not just from a affordability perspective or a cost perspective, but from that workforce perspective, I think it could make sense. So let's change what we're doing now, but how do we get on a road to make sure a year down the road we're doing everything we can in these areas? I think it makes sense. So appreciate the board's feedback and comments on all of that. All right. I think it's a good time to move to public comment on this agenda item. Oh, are we still? I saw a few of you jumping up and down. Okay. CJ, I think going to CJ now.
Yeah. Good afternoon again. So I'll be providing an overview of the regulations as currently drafted to the board today. This is my third time, I think, giving this presentation, so we'll see if it's like fine wine or not. And also be providing an overview of the feedback we've received from the hearing that we held in November, feedback from our advisory committee, as well as written comment that was received on or before December 1st. We'll be collecting all of your feedback from the board, aggregating it with all the feedback that's been received, and then we'll ultimately be responding to the comments that we have received next month after we've had a chance, again, to visit with the public, the advisory committee, and the board. A little context setting, I do want to note that the regs as they're drafted are very much geared toward getting us through the initial baseline report, and there's a potential, or dare I even say likelihood, that we will be updating and revisiting these regs in subsequent years as the program develops and evolves. Additionally, as Vishal noted, the regs do not speak to the totality of the data sources that we will rely upon in developing the baseline and subsequent annual reports, but are the basis for acquiring the data from submitters that we've not identified alternatives to, because as we also know, the statute does direct us to maximize alternative or substitute data sources to the extent that we can. So, brief overview of the statute for implementing these regs. We are required to adopt the emergency regulations to establish requirements for payers and fully integrated delivery systems to submit data and other information for total medical or total healthcare expenditures and per capita THCE. We're going to use this information to prepare a baseline report on healthcare spending by June 1 of 25. Annually thereafter, we'll prepare a report concerning healthcare spending trends and underlying factors, along with policy recommendations to control costs and improve quality, performance, and equity within the healthcare system while maintaining access to care and high quality jobs. And we'll publish our first annual report by 2027. The basis of its analysis will be the THC data for 2024 and 2025, as we've described in prior meetings. So quick overview of the regulations and kind of what they consider or encompass. First, they define the terms that are used within the regulations. They outline the scope of the regulations. They specify who is a required submitter and how voluntary submitters may request to participate in submitting data. In general, though, a payer or fully integrated delivery system with 40,000 or more beneficiaries or covered lives is calculated by December 31st of each calendar year prior to the submission year must submit THCE data if the entity meets any of these criteria. It is a Medi-Cal managed care plan contracted with the Department of Healthcare Services to provide full scope benefits to Medi-Cal beneficiaries. There's a 1-year exemption on that. Enrolls or insures covered lives in Medicare Advantage products under Medicare Part C. Enrolls or insures covered lives in commercial products in California. Non-mandatory submitters may request approval from OCA to register and submit data. The regs also explain how submitters in plan-to-plan contracts should coordinate data submission with subcontracted plans. In short, if a required submitter is the directly contracted plan in a plan-to-plan contract, the directly contracted plan must obtain the necessary data from the subcontracted plan and submit that data through the system. The regs also establish deadlines for submitter registration and data file submission. All required submitters and approved voluntary submitters must register in the data portal to submit data through the system by April 30th of 2024. For their initial data file submissions, which will be for the 2022 and 2023 calendar or reporting years. After September 1st, 2024, and annually by May 31st for their annual submission. The regs also establish other requirements related to data specifications, such as test files, data acceptance and corrections, variance requests. If OCA determines a previously accepted file contains initially unidentified errors, it will notify the submitter through the data portal. The submitter must respond through the portal within 3 business days, and OCA may make multiple requests for corrections or resubmissions. The submitter that's unable to submit data files meeting the file intake specifications may request a temporary variance. Going into a little more detail on several of these. So additionally, want to note that the regs, emergency regs, incorporate by reference the total healthcare expenditure, or the THCE data submission guide. Want to note that the data submission guide is intended for payers and fully integrated delivery systems to use when extracting and aggregating data for the submission to OCA. It's fully, by it being incorporated by reference into the regs, has the force of regulations. In order for us to amend or change or make updates to it, we would have to go through the same rulemaking process that we are currently. So it's not as though OCA would be able to just make changes to this in a sub-regulatory fashion. So any such changes would go through a full process. And it's designed to be user-friendly for the entities and analysts that'll actually be pulling and submitting the data to OCA. That's why we're using the data submission guide mechanism as opposed to all of that being in regulatory text. This specifies that submitters will not be required to submit data files for the Medi-Cal managed care market category until September 1st, 2025. Annual submission deadline. OCA will get Medi-Cal data from Medi-Cal MCO data from DHCS for the first year. That is part of our attempt to, again, maximize to the extent possible existing data sources. It also incorporates by reference the attribution addendum. This contains a list of provider organizations and unique identifiers to be used when attributing total medical expenditures. The currently drafted attribution addendum and the attribution addendum is intended to be a living document that will be expanded upon and further enhanced as we go forward in this work. So submitters will report total medical expense using pipe delimited text files to the forthcoming THC data portal. There are 5 file types. In total, there's a statewide total medical expense file, which breaks down total medical expense by market category. There's the attributed total medical expense file, which will attribute costs and expenditures to organizations listed in the attribution addendum and broken out by market category, age, and sex. There's the regional TME file. This is the total medical expenses broken out by market category and geographic region. Again, we're using the covered California rating regions, and for Los Angeles County, we're using the LA County Service Planning Area regions. And there's also a pharmacy rebate file. This is for statewide medical and retail pharmacy rebates broken out by market category. There's also an attestation file that confirms that the instructions in the guide were followed when preparing the data for submission. Submitters will report total, as currently drafted, submitters will report total medical expense categorized by claims payments, other member level payments, and non-claims payments. In addition to file layouts and field specifications, the data submission guide provides instructions on reporting allowed amounts from claims, including member responsibility after a runout period of at least 180 days, including claims for California residents regardless of the site of care when the payer is the primary on the claim, attributing member level expenditures to organizations listed in the attribution addendum using an ordered methodology, including estimates for members when certain benefits are carved out and claims data are not available, calculating standard deviation as a per member per month value, requesting data variances if data submission requirements cannot be met. So in short, to date, we've published the regulations. We held our workshop in November. We had our advisory committee discussion in November. We have also received comments from 5 submitters as of December 1st, and we're having our board discussion today. We plan to follow back with the board in January, where we'll be responding to the comments that we've received, and ultimately are aiming to submit the regulations to the Office of Administrative Law in January or February for them to become effective in spring of 24. Before I dive into the comments that we've received, and I think we could have a more fully throated discussion, I do want to see if there's any questions about what's been presented to date or so far.
Go ahead, Richard.
Yeah, thank you, CJ, for the presentation. So in terms of member responsibility, right, we have plans, including Covered California, that have, deductibles and things like that. I presume that for a plan, even if someone's below their deductible, so they're not reimbursing anything, they would still be reporting the claims of things that the members themselves had to pay for because they were below deductible.
Yeah. So some of the data that we'll be getting from the payers includes any copays made by patients, whether they've met their deductible or not.
Okay. And then the other question, I guess, and most often it's not the insurer that actually collects the deductible or the copay. So is this what's actually collected or what they project is collected? Because, so I realize there may be a discrepancy there depending on the situation, in terms of what was actually paid.
Yeah, that's a good clarification. We've said this before at other meetings, I believe, but it's the consumer obligation to pay, not whether they actually paid. So Okay. Yeah, so it's what they accumulate towards the deductible, and it's the members' obligation.
Yeah. Okay. I mean, the reason I bring that up, one is that, I mean, in the ideal world, actually, they would be the ones collecting the copay and deductible, so we take the middleman out. But that's a whole nother story. But I think that then you'd have the information because they know exactly what they collected. I think that this is one of those things where probably the data doesn't exist in some database somewhere, but we should probably think about looking into exactly how big of an issue this is, because if we're talking about what's the actual total medical expenditures, and if you're the person on the front line taking your patient, they said they're short on money, and and I don't know. I mean, I think the contracts say you have to, so you probably would never actually say it, but sometimes you try to help people out, and but that won't get reflected anywhere. And so I think we should explore exactly how much of that is going on or not. And I know that some people even have the expectation that, hey, you know what, you're supposed to waive my copay, and I've seen that happen too, right? So anyway, I think something that we should think about having someone look into in some way to get a sense of the magnitude of that, and what's the discrepancy between what's actually paid and what we're quote attributing to that.
Elizabeth.
Thank you. I know there are constraints on the availability of some data that we would like to have, and this was a great example. I'm thinking ahead, though, to the utility of this information and how we are going to get insight into some of the drivers of the costs, and wondering if you will be collecting some of the new TIC data and the new hospital pricing data that is now being federally mandated, so that we start to get some insight, not just in total aggregate, but what's being driven by price, utilization. I mean, the things that we might have that would have levers around them that we could address. Also, if it'll be segmented by rural and urban. So again, as those federal mandates, expand, there's a bill that passed last week in Congress, are just making sure we're tracking that so that we have visibility into everything that will be allowed with the new transparency requirements.
Yeah, that's a good point. The summary level data we're going to get through this data collection is, it is aggregate, and it's only going to tell you so much. It could say the inpatient category is growing, but you won't know why. So we do intend to return to the board with to describe OCA's approach for cost driver analysis, which will include supplemental data sources like the HPD, and regarding other data sources, the price transparency data, as that's being more, as hospitals and payers are reporting more complete reporting rates, that'll be something we could look into as well, for drivers, of whether it's price, price being one of them.
And I would just add to that list sort of pharmaceutical pricing, PBM admin costs. I mean, those are key drivers for medical spend. So again, I understand the existing constraints, but to Mark's point, making it clear that's where we're headed will help build the operational capacity. And again, I think we're going to have more and more visibility to take advantage of.
Thank you.
Rick.
Thank you. To Richard Pan's point, I do think, with some amount of imprecision that MEPS would be able to provide at least, some information on what fraction of the patient responsibility is actually paid by the patient. It's not going to be great, but they at least try to get at that. And then maybe this will be covered in your subsequent presentation on the cost drivers. And we've discussed this before, and I think, the answer we came to was, well, we can't do it yet. But I do think that, given how much interest we as a board, and more importantly, the legislature and statute and the public have on the primary care and behavioral health benchmark questions, and trying to increase investments in primary care and behavioral health, that it's a big miss to not be collecting information on that through this process. And I can imagine that trying to get at that through the HPD, maybe that's the plan. Or maybe the plan is, well, we're not going to do it in year 1, but we're going to change this in year 2. But at least having some line of sight to, we want to increase investments in primary care and behavioral health. We don't know how much is being spent now, much less how much is being spent by various medical groups or covered entities, and having some line of sight into how that's going to change would be valuable for me, at least, and I think probably for other board members in the public.
Yeah, we early next year we'll share kind of more specifics on which board meeting. In early 2024, we'll kind of give you a cadence of topics that are coming, and primary care spending will be one of them. There's an active subgroup that's part of the investment and payment work group that Margareta Brandt leads, and they're actively looking at definitions for kind of providers, care settings, service categories, services by code, procedure codes. So they're working through that process so that we could funnel something up to the board on our approach for how we want to measure primary care spending. So it's not going to be part of the baseline report, but it will be part of the regular cadence of annual reports that OCA needs to do.
So to follow up, I mean, is the thought, and maybe you're not there yet, that these data would be collected through analysis of the HPD or through some modification of the regs that we're looking at now?
We would update the regs. So right now, the category that CJ went over, it shows professional spend as just kind of this broad bucket. That bucket would be disaggregated into primary care, and then in the future also for behavioral health as well.
Yeah, I mean, it makes some sense. I guess I'll be interested when you get to this presentation about the advantages and disadvantages of trying to do that through collecting information from payers versus through the HPD. I can imagine some reasons to do it in each direction.
Yeah, I think I don't have the answer on the top of my head, but I think given some of the high share of non-claims spending and getting to that granularity, I think that's why we're going to do it through this process.
And just to chime in here, and I mean, in addition to MEPS, maybe it goes without saying, but I think on the hospital side, for most hospitals, we have pretty good information already coming into HCI on patient liabilities and bad debts, and those should be synced up here. And obviously that leaves a big gap with medical groups and others. But given that, I mean, I second and triple Dr. Pan's question about the amount of administrative burden and costs that's being put on medical groups, so that set of data, I hope we can figure out how to get, at least from the biggest ones. Oh, Richard, go ahead, please.
Yeah, I'm trying to think in the scope of this. I mean, I think about because you're getting Medi-Cal data from DHCS, right? And I'm also thinking about some of the 340B discussions we had because but a lot of times, and we're doing CalAIM, right? So clinics, and whether you want to count that under medical expenditures or medically related, but do things like transportation, right, to get you to and from clinic, right? When you're, again, addressing a very low-income population, some of these sort of
things are adjacent to, but I don't know what you call them, medical or not, but that sort of helps them get their medical care, right? Whether there's in your discussions with the ETS, we're going to try to capture any of that, especially as we're rolling out CalAIM or not, and how that fits in. It's not technically medical expenditures, so we're the Office of Healthcare Affordability, but perhaps there's also a role for us to help inform DHCS whether some of the stuff that we're doing that's healthcare adjacent actually helps with the healthcare cost side of things. So again, in your conversation with DHCS, I'm not sure, is it just to the actual, billing or, capitation, or is there some conversation about trying to capture some of this other information or some collaboration between DHCS and this office to look at? It's also part of perhaps maybe even evaluation of how some of the CalAIM pieces might actually affect healthcare, actual healthcare expenditures.
Yeah, we with these new covered benefits for ECM and community supports and in Medi-Cal, we will be having those conversations with DHCS as those benefits are being implemented. And then some plans cover transportation on their own. So to the extent it's a non-claims payment, our data collection regs would encourage them or would direct them to report that.
Yeah, and also I don't know to what degree DHCS may collect information from, for example, not all of it's from the plans, some of it's from the clinics themselves, right, or from safety in the hospitals, right? So there's a lot of different layers where it comes. Sometimes the plan does it, sometimes it's the clinic. They talk about how they use 340B money for that, and they can't do that anymore, et cetera. But so I don't, in your discussion with DHCS, and then of course CalAIM itself has this whole other things layer. So whether there's a way, whether that's something we need to capture, especially as we're talking about equity and people's access to healthcare, some of these, I guess, healthcare adjacent expenditures may be actually kind of important, and either the absence or the presence of them may drive up or down healthcare spending in this population. So I don't know to what degree DHS even tries to capture some of this, especially by some of their providers. So it's not just the health plans, it's also providers, like I said, clinics, safety net hospitals.
Yeah, that's a good question. But if it's a Medi-Cal covered benefit, and yeah, our focus is plans in terms of what's being paid for. If a clinic is somehow funding a service on their own, it would just be a huge lift for us to somehow capture that.
No, I get it, but there might be some interesting sources of information from counties, because a lot of counties run clinics from the health. Anyway, perhaps on the shelf of things to explore, and maybe for any of the academics who are listening, maybe someone can try to help us do a study there.
So we pay for a number of these kinds of things in our as supplemental benefits in our MA plans, transportation services, post-discharge meals, targeted home care, et cetera. Those are good for the health of our members, we know. We're also betting that they are going to be good for our bottom line because they keep people out of hospitals. We've had a bear of a time because our sample, I mean, it's a long path to see savings in our own data. There's not very good literature out there on these. I think there's maybe a little bit on post-discharge meals and not a lot else. But would be terrific if there was an eye on this. I mean, one, they're healthcare investments, just full stop. So they should be counted. But two, it would be great if we had an eye on how they affect total expenditures. I think that would be a huge contribution, because there are a lot of people out there, me included, who think that there's a lot of opportunity there to improve outcomes and to lower costs. But again, not a great evidence base, just largely anecdotal.
I think in preparing the CalAIM work, obviously in our submission with the federal government, there is a sort of return on investment, kind of budget neutrality conversation. And it's both hard to do. I mean, I think you all know we always make the claim, hey, this is going to be budget neutral, it's going to save money. And at the end of the day, it is often hard because our data sources are tough and they are expenditures, no doubt health expenditures. But in some settings, like I think about the housing piece, which we're really deeply investing in the CalAIM Medicaid program. And arguably, if other parts of our safety net social services took care of those expenses for people with health issues, they wouldn't show up in the health bottom line per se. So it is a bit of a tricky situation at the moment, but I think if we could provide some clarity on how to do that effectively. I mean, as the conversation's going, I think about the primary care spend focus, right? We are not, the triple aim is important, but if we said, hey, look, we drove down primary care spend, I think everybody around this table would be super concerned. So our social drivers of health similarly focused, and I think it's an important conversation for this, the staff and the team to sort of grapple with. And CalAIM is a natural, probably the biggest laboratory to think about that in the nation at the moment. So I appreciate the flag.
All right. So we're going to provide an overview of the public comment that we've received on the regs to date. We've received written comments from the following organizations: California Medical Association, California Association of Health Plans, California Hospital Association, Health Access California, and Americans Physicians Group. So we're going to summarize the comments, and then after hearing from the board, our plan is to consolidate and respond to the comments in January. And we'll provide an update on any resulting changes to the proposed regulations at January's board meeting and advisory committee meetings. So so we tried to bucket these comments into themes. We've got several requests for revisions to different definitions, including how we defined allowed amount, the attribution method, claims runout period, claim service categories, long-term care, market categories, non-claims, payment categories, and pharmacy rebates. We've received comments related to risk adjustment. So one commenter requested OCA expand its risk adjustment methodology to consider disabilities, chronic illness, and other complex health conditions, as well as more granular age bands. Another commenter requested OCA formally evaluate clinical risk adjustment methodologies alongside age and sex risk adjustment prior to spending target enforcement. This commenter also asks OCA to consider the use of truncation, where we would cut off the high-cost outlier costs. Comments related to attribution. So the majority of public comments received by OCA were related to challenges surrounding attribution of TME to provider organizations. One commenter requests that data collection distinguish between PPO and HMO product lines. Two commenters expressed concern about OCA's use of payer-developed attribution methodologies. One commenter expresses an understanding of why OCA took this approach. Two commenters request a process for attribution review, validation, and dispute prior to making data publicly available. One commenter expresses that TME attribution will generally work for HMO members and providers, but not so well for PPO and EPOs. They suggest working with providers to develop a physician organization registry. Continuing on the attribution themes, one commenter expressed concern that OCA's attribution approach would not sufficiently mask individual member-level data. One commenter requested OCA work toward a standard patient attribution methodology. One commenter expresses concern that OCA's attribution methodology would not attribute TME for a majority of Californians. All commenters expressed concern regarding omission of OCA's attribution addendum and lack of clarity regarding how the addendum will be updated. Other themes include the claims runout period. Commenters expressed concern that the proposed 180-day claims runout period is too short in light of the Knox-Keene Act provisions regarding prompt payment and recoupment. Incorporation by reference, one commenter expresses concern regarding OCA's use of a data submission guide incorporated by reference. Another commenter generally supported the use of a data submission guide, but requests assurance that changes to the submission requirements would involve robust stakeholder engagement, which, as we discussed, it would be subject to the full sort of rulemaking process, emergency rulemaking process. For fully integrated delivery systems, several commenters request clarity regarding data submission expectations for Kaiser. And then for self-insured lines of business, one commenter recommends not requiring plans to report ASO fees. Related to administrative costs and profits, several commenters request clarity regarding how payers and fully integrated delivery system administrative costs and profits will be collected. Non-payers submitted data. Similarly, several commenters request clarification on how and when Medi-Cal supplemental, fee-for-service, and dual eligible payment information will be collected, as well as traditional Medicare. For Medi-Cal data collection delay, one commenter requests more information regarding OCA's decision to delay the collection of data from Medi-Cal managed care plans. And for health systems, one commenter requests more information on OCA's plans to collect data regarding hospital systems. And then lastly, some of the key themes that we pulled or heard from the advisory committee offered feedback on the draft regulations, including one provider suggestions that OCA define a standard provider attribution methodology for insurers to use, a provider suggestion that OCA account for changes in plan design when assessing provider organization capitation payment trend, a provider suggestion to create a category for spending associated with alternative sites of care to hospital outpatient, for example, imaging centers, physical therapy centers. A recommendation to add 2 Permanente medical groups to the provider organization list, which we're doing. I know Board Member Cronick, you were also at the advisory committee. I don't know if you had any other feedback that you wanted to offer that you heard that we did not highlight here.
CJ, I think you did a very comprehensive summary of what we heard. Couple of things that sort of slipped through, not kind of high priority. I think one commenter, or one of the advisory group members, thought it was important to value email and try to get some kind of information about resources that went into email communications with physicians. We've talked already here. I'm not sure you highlighted it. There were comments about administrative costs at the provider level, comments about out-of-pocket, out-of-plan for behavioral health. But other than that, nothing to add.
So I'll hand it back to the secretary.
Okay. For the sake of time, I would like to move to public comment unless there's any burning comments, questions. Rick.
I'm not sure quite what burning is, but I did think that the comments requesting the data collection distinguish between PPOs and HMOs is important and makes a lot of sense. And clearly the attribution methodology, there was in the advisory committee lots of discussion about should OCA require a standardized attribution methodology. For what it's worth, my sense is that your approach of allowing payers, at least in year 1, to use whatever methodology they've been using makes sense, because requiring a standardized one in year 1 is likely going to result in payers saying, I can't do this. Collecting information about what payers are doing, I suspect that their attribution methodologies aren't all that different, and maybe in the future, moving to some sort of standard methodology would make sense. But even so, clearly the PPO side of the world is going to be much more, the information, the attribution is going to be much less good than the HMO side of the world. And so separating this by PPO and HMO made a lot of sense to me.
Richard?
Go ahead, Vishal, and then Richard.
Yeah, we do intend to have that breakout of HMO and PPO.
Well, just brief, I agree with a lot of what Richard said. I think one of the things we're going to struggle with, and attribution is going to be one of those spaces, especially when you talk about HMO versus PPO, is that people want things, or patients will want things. And so the question is, to what degree do you expect those of us who are in the healthcare system, providers, people, you know, the plans, whatever else, to tell people no when they want something, right? And so, for example, on the PPO, when we do attribution, and I actually agree, what we should do is collect information on how they're going to do all the attributions, right? So not only this is exactly, and then we can figure out. I do think eventually we have to get to some attribution guide, but perhaps the first year may not be the year to do it. We should collect data certainly on how they're doing the attribution, but you know, to the degree that things get attributed to someone who really, I mean, your costs are attributed to someone who actually, those are actually driven by patient desires and patient choices, and actually even patient, you know, the patient able to do it. That's the nature of the contract, is not exactly fair to the provider who doesn't actually control what the patient decides they want to do or not, right? Depending on the nature of the coverage. And I think that's what we run into with the PPO attribution problem. So I think this is something we're going to come up against more than once, where, you know, patients do want certain things. Sometimes they want antibiotics for colds, right? And you keep saying no, 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 and they go around, they find somebody until someone actually writes that prescription. You know, and so that's something we're gonna have to deal with.
That's a very real point that you raised, Dr. Pan, and we are tracking that issue, and we've established a hierarchy in the way that we're asking submitters to report. The first one is if you're in a capitated delegated arrangement where you do have you are delegated care management or utilization management, and then the second order of operations is total cost of care ACO arrangements, which can include both HMOs and PPOs. And then the third one is this payer developed attribution method. We want them to follow that order of operations. And then it's that third category of payer developed attribution where we hope to learn how payers are doing it, and then that could potentially inform how what guidance OCA gives submitters in the future.
I want to make sure. Any other comments? Okay. Safe to move into public comment now.
Okay, we will now take public comment, starting with members of the public who are joining us virtually. Please use the raised hand feature to indicate your desire to speak. And we do see a hand from Steve McDougall. Steve, we invite you to unmute.
Members of the board, good afternoon. Steve McDougall with CFT and the Salinas Valley Federation of Teachers based in Monterey County. Thank you, staff and board, for your guidance on the work so far. But I want to emphasize and make it clear, it may seem odd to request that Monterey County have its own regional TME, but it is so perverse here that it would be an exercise that would be of interest, I think, to the board, that if Monterey County had its own regional TME, it is a test case in how bad things can get and how far down the road we've gone in Monterey County with our own TME, that we needed help a decade ago. And it's not sustainable. So I just want to say it's not too late. It seems kind of quirky, but actually it would be helpful to the residents of Monterey County. Thank you for your time.
Thank you. Turning to members of the public here in the room at the podium, please go ahead.
Hi, excuse me, Beth Capel for Health Access, and we appreciate the overview of how the variety of information is going to be gathered. It would have been helpful to have some of that before we submitted our formal comments on the regs, but we know, given this process, there'll be other opportunities to submit comments as well. A couple of substantive points. The list of physician organizations that is currently in the attribution addendum starts with the list of risk-bearing organizations and adds a few other about organizations. It captures, by our estimate, using the data from DMHC's Financial Solvency Standards Board, about a quarter or a third of consumers in California. That seems a little long. We've understood the discussion about we're not going to capture everything, but that seems a long way from where you want to be. And so it's helpful to hear that you plan to develop it over time, but that seems a pretty big gulf between where what you're collecting initially and where you hope to get to. We also note that it excludes not only the Medi-Cal managed care providers, but many of the Medi-Cal physician organizations, whether it's the counties that provide care or the community clinics. Second, Kaiser appears to be treated as a black box. It appears that the only data that's collected is the total capitation. So that is problematic and not in concert with the law. Third, with respect to the discussion we've had today about overhead at levels other than the insurer, we would note that the overhead for risk-bearing organizations is available to the Department of Managed Healthcare and has been collected for 20 years. And while you couldn't attribute it to specific organizations under existing law because it's not publicly available, you could certainly look at things in the aggregate or at the regional level, and that might be helpful. Finally, we note with respect to Kaiser, they impose a care coordination fee, which the last time I heard was on the order of 28% of the premium. So that's kind of a big chunk of money. That's kind of worth thinking about. I think the justification I have heard from them over the years is you can't do an apples to apples comparison. We make applesauce, to which I can only say last time I checked, applesauce had apples in it. Thank you.
Thank you. Looking back to the virtual room to see if there's any raised hands. Not seeing any at the moment. Looking back to the room here. And we've got someone coming to the podium.
Good afternoon. Mark Farouk with the California Hospital Association. CHA supports collecting data from payers with some concerns that we have outlined in our previously submitted letter. We previously expressed support for the proposed approach of collecting total healthcare expenditure data from health plans and insurers for enrolled insured state residents. Health plans and insurers are better positioned than providers to comprehensively identify and report THCE. Our most fundamental concerns relate to the absence of rules and process for validating the expenditures attributed to providers and the rules for how health plans and insurers must perform this attribution. While we understand the office may wish to learn more before establishing a standardized methodology, the current regulations set no parameters around how this is done when attribution isn't determined by contract arrangement, which will result in incommensurable data. Additionally, we remain concerned that there's no mechanism for gathering clinical risk information in the proposed regulations, meaning that clinical risk adjustment may not be or will not be considered. Failing to include clinical risk adjustment could punish providers who serve particularly vulnerable populations. Finally, it is unclear how stakeholders will be consulted when changes to the data collection regulations and guidance are being made. We look forward to working with OCA, the board, and the advisory committee to improve these critical issues before the draft regulations are finalized. Thank you.
All right, looking to the virtual room. No sign of raised hands. And seeing no one else coming up to the podium here in the room, that concludes public comment for item 5B.
All right, thank you. Thanks, CJ and Vishal. We move into our last item. It's a long one, nearly 30 slides, so a lot of content to go through. We are a little behind, even though it feels like we have a few hours before the end of this. We are behind by about 25 minutes. So I'm going to ask, unless it's a critical interruption for clarification, that we as a board kind of wait until the natural place to sort of interject and ask some questions, and then we'll try to obviously leave quite a bit of time for public comment if we can on this item, because it's a critical piece. And I failed to say when we reconvened that Sandra Hernandez, who is not here, is listening, has been listening to the entire meeting. It's not in a place to chime in, but just for the other board members' understanding, as we pick up meeting after meeting, some of the content she's staying with us and has let me know. So good news. All right, for this next item, Vishal, am I turning it to you to bring up the cast who will be presenting?
Thank you. So for today, we'll be discussing, we'll be reviewing advisory committee feedback on board discussions to date for the spending target methodology. We're also going to be responding to a board member request that OCA consider an adjustment to the target related to technology related factors. And then we'll also present OCA's preliminary proposal for multi-year statewide healthcare spending targets. Next slide. So at the November advisory committee meeting, members provided input on the following topics that we covered: historical healthcare spending growth, economic indicators, and the use of historical versus forecasted growth, population-based measures, the duration of the spending target, whether it's multi-year, number of years, et cetera, and then considerations for adjusting the spending target. So as far as the, our staff recommendation that the spending target be based on historical spending growth, or some members were divided on limiting the target to historical spending growth or linking it to historical median income growth. OCA had made a recommendation that to the board in the October meeting that the spending target be less than 5% and be benchmarked to an economic indicator, specifically median household income. So industry members raised concerns that past performance is not reflective of future trends, especially given the rise of inflation in late 2021. Other members generally supported the recommendation to link the target value to median household income. Some members voiced support for a more aggressive target to address the lack of consumer affordability, while others argued that the target be realistic and reflect actual provider costs. Some industry members expressed concern that a too aggressive target would mean fewer providers to care for patients. Member views on setting a fixed target value or phasing it in, which was an active discussion topic at our last meeting. There was mixed views on that. Most members favored a fixed target value for a duration of 3 to 5 years. And then one plan argued for a phase-in given multi-year provider contracts. Next slide. So in general, providers and plans supported adjustment, while consumer and labor advocates did not. A member asked for additional information about the age sex analysis OCA performed and suggested that the weights be California specific. Industry members suggested that OCA perform additional analysis indicating that every dollar counts, while others noted that adjustments are too complicated and chronic illness status adjustments may have negative equity implications in terms of certain diagnoses could only be coded if someone has the means to seek care in a doctor's office. Some advocated for deferring a decision on adjustments until the program evolves and more information is available. Members agreed that the board should selectively use its authority to prospectively adjust the spending target when conditions warrant, members further said the board should be transparent about the rationale for revisiting or adjusting the target. Next slide. So I just want to pause here for any, or I'll move on to the adjustments related to healthcare technology. The next slide is just going to cover the statutory concepts. And we usually bold the factor that we're going to be hitting on in terms of the statute. So today we're going to be talking about technology, trends in the price of healthcare technologies, which is one of the many factors listed in the bolded bullet for considerations for future adjustments to the cost targets. And for this portion of the agenda, we'll be having Michael Bailett lead the discussion.
Good afternoon, everyone. So during our last meeting, Richard, you made a request that we consider possible adjustments for technologies, and you referenced the technology in the statute. Specifically, the statute says that the methodology for the spending target should review potential factors to adjust, including trends in the price of healthcare technologies. Now, interestingly, it says for future targets, which suggests not for the initial target. I'm not sure why, but that's how it was drafted. That aside, I want to share information with you that we gathered on healthcare technologies and price-related healthcare technologies to inform your consideration of whether there should or should not be an adjustment for it. Next slide, please. So first we have to start with a definition of what are healthcare technologies. The statute does not define the term. So we identified a definition developed by the World Health Organization that references application of knowledge and skills in many different ways, and you can see them in boldface here. So this definition encompasses both technologies for which there is a direct reimbursement and also technologies that are non-reimbursable but are part of the infrastructure of the delivery system, such as use of blockchain or more recently AI. The Kaiser Family Foundation has observed there's little in the field of medicine that does not use some type of medical technology or care that has not been influenced by new technology. So it is ubiquitous when we think about healthcare delivery. Next slide, please. So there's no question that healthcare technology influences healthcare spending and the cost of healthcare. There's been lots of research on this. Technology can increase the cost of healthcare or healthcare spending. It can also produce savings too. I think we have to acknowledge they're both. If we were to consider adjusting the spending target for healthcare technology, we would need to be able to anticipate what would be the future development and application of technology and its impact on healthcare spending, because we are setting spending targets prospectively. This is difficult to do because the development of new technology is not predictable, and sometimes it is in response to events that we can't predict. The example we have here is that mRNA technology that was rapidly applied to develop COVID vaccines. Next slide, please. What's the impact of technology of price of healthcare technology? So the price for healthcare technology is set at least in part through negotiation. And some of the costs, as I said earlier, are directly reimbursed. Some of them are not, but they might indirectly find their way into the cost of healthcare. In order to develop an understanding of trends of price in healthcare technology, it would require OCA to have a very technical definition of what it means by healthcare technology, certainly beyond the World Health Organization conceptual definition I gave to you. There would need to be a way to track prices of healthcare technology in all of its forms, and then to consider what those prices might be for technologies that have not yet been developed or at least applied in healthcare. So as we assess healthcare technology and how healthcare technology development and prices of healthcare technology might be used to influence or adjust the spending target, we see lots of challenges in doing so. Next slide. Next slide, please. Okay. Sean.
So the staff recommendation to the board is that there be no adjustment to the value of the spending target. And just want to pause here for any questions or input from the board.
Yes, Richard.
Since I was called out as the person who asked this in the first place. So what I see is that there's acknowledgement that technology is a major cost driver. I get you can't see into the future, but that we make no adjustment to the value of the spending target. So in some senses, I'd guess is that, yes, we can't predict the future, but there's also stuff we know even now that are coming down the pike, right? So for example, FDA just approved gene treatment for sickle cell. Do we anticipate that, you know, given the number of, and again, depends on how many people are affected, et cetera, right? Not everything. Is that something we should be incorporating, or do we tell everyone? And because after all, do we want people? I mean, we could freeze healthcare and say, guess what? We don't want to incorporate any advances in healthcare, and we'll just freeze it right here, and that's. But I don't think people would find that acceptable, right? So there is going to be some projected cost. Now, whether we build that into a initial target or not, but I think we need to factor that in. I don't, you know, and of course I get it. The price is also being, you know, is going to be negotiated and so forth. Just like we went through this with Sovaldi, right? With the hepatitis C, we're going to perhaps see more of this. In some senses, fortunately, these new items actually are cures in some ways. Maybe that might be a little bit of I don't know if that's an overcall on the gene therapy for sickle cell yet. That at least the hepatitis C was actually a treatment that you know, you could get reinfected, but it's versus a ongoing chronic thing. So with the larger upfront costs. So in some senses, one could argue, given the alternative treatment, that frankly it was actually less expensive over time than not. So I think we have to come up with a mechanism to deal with at least technologies that occur at scale that we need to acknowledge that there are technologies that that people should have access to, that and if it's at scale where it actually affects that we need to make adjustments for that, unless we want to just say we just want to tell people like, sorry, we don't incorporate this, because I don't see us saying that we'll, you know, by the way, healthcare now is not the same as it was 20 years ago, right? In terms of what can be delivered, right? Some people might argue they don't like that or not, but I think most people want to try to benefit from the advances in science that we've had, including, by the way, mRNA, hopefully vaccinations. Interesting enough, that's where we have more of a problem with people than the technology. The technology will save lives. It has saved lives. People may be refusing to use some of it for various reasons, and that's actually creating more healthcare costs. But I think we do have to come up with a way to adjust for technology because it's out there and it's happening.
I mean, part of the challenge with healthcare costs is the prices that are associated with these developments in technology. And if we treat them like gravity, I just think we're kind of taking the teeth out of what we're doing here. I mean, these all translate into drugs, or some of them translate into drugs, some of them translate into other technologies. You know, there are these questions about what the healthcare industry should be investing in and not. I mean, we can't accomplish anything if we treat all of the things that are part of healthcare as just factors that we have to add on or not factor in, and we get to something that isn't very meaningful. That would be my concern with trying to keep them out somehow in the total calculation.
Go ahead, Richard, and then we'll come back to you, Rick.
Well, I mean, I think, first of all, we don't have to take it like at, so for example, we don't have to take exactly the price that someone may initially offer for that or list price or something, right? But I think we need to acknowledge and perhaps make adjustments, especially as, again, it's not for every single thing. A Me Too drug? No, right? So certain types of technologies really aren't make a significant difference in someone's health trajectory. Some others do, right? And those we need to at least figure out some way to incorporate. Otherwise, we're sending a message that actually that's not something that we want, and that actually raises some equity issues, right? As well. I mean, so that in terms of like, oh well, guess what? We're not going to try to incorporate the fact that we have something that's a dramatic advance, and the make that basically acknowledge that should be available to people. In fact, in some ways, actually, for interesting for Savaldi, we actually did, because we actually allocated a chunk of money in the state budget for a lot of people for that. We also negotiated with the manufacturer.
But part of why we added all of that money was because the price of that drug was so high. I mean, if you take the sort of modern equivalent or current equivalent with the GLP-1s, which are budget busting for a lot of purchasers, that is a significant advance. We think it's early days, but significant advance in medicine. But if we just assume that these are things that are part of the adjustment, then we've taken the conversation away about whether or not the prices that are associated with them are excessive. The other thing is that the healthcare industry has a long history of investing in some technology that is beneficial to health and some that is just additional cost. And if we just, if we take that out of the calculation, we're not, the incentive to be mindful about how those choices are made is diminished.
Okay, I'm going to invite some other people to the conversation. I think we had Rick, and then Elizabeth, and then Ian, and then David, and then we can return.
Yeah, Michael, thank you for your presentation. I would disagree with one thing that you said, which was that in order to, if we did want to make some adjustment for technology, that we would have to anticipate Ozempic or GLP-1s or whatever, the specific technologies were. And if we wanted to adjust for specific technologies, then we would have to do that. There is another approach, which is to adjust for sort of technology on average, and to say that, over some relatively long period of time, we do think that some beneficial new things are going to appear. That's what's happened over the last 20 years. It's likely to happen over the next 20 years. Many of those things, as Don said, are going to get priced much higher than they should be. And we don't want to just say, yeah, that's fine. But we may not want to ignore it entirely either. And we probably don't want a healthcare system 20 years from now that looks like the healthcare system today. We want those new technologies to come. And then whether that is possible within a healthcare system that's growing at 3% or 1% or 5%, that's where it gets tough to figure out. But I don't think we would need to to be pricing individual technologies and be anticipating
I agree with
individual
that.
technology.
Although I
be able to
question
adjust for it.
our ability to forecast based on the past. I mean, for example, if you look at the incredible rise of the introduction prices of new drugs in the last decade, you could not have predicted that. I don't think. If you looked at
Yeah.
if 10 years ago we looked back 30 years.
Right. And at the same time, in the last decade, and the report that Vishal discussed at the beginning of the meeting, the CMS report showed that in the last decade, health spending as a share of GDP has been flat. We've been at GDP plus 0 since 2010. So even with these new drugs, we're at GDP plus 0. The path that the staff recommendation, and I'm jumping ahead here, excuse me, would have us on will be at GDP minus. I'm not sure exactly, but I think maybe GDP minus 0.5 or 0.1 or 0.5 or 1. That would be unprecedented both in the United States and in Western Europe. We're California, we can do unprecedented things, but it is in my mind at least raises some question about what would the healthcare system look like, and can we accomplish that in a way that will increase quality, increase equity, and accommodate the new stuff that we actually want and will produce value. And maybe we can, but again, it's so different than anything we have seen either in the US or Western Europe that it's at least nervous making. And so to not accommodate, not to have some explicit accommodation for new technology is nervous making. I mean, nothing else to say.
Yeah, I just think that technically it's really challenging to do. And so my suggestion is that if there is a Sovaldi technology experience in a given year, that retrospectively, when Oka and the board have a conversation, they say, whoa, something happened big in technology this year that we didn't see coming. It influenced spending growth, and we want to take that into consideration when we're assessing performance against the spending target. I just think it's otherwise really hard to project it because I think technology is lumpy in terms of its introduction and its spending impact.
Okay, Elizabeth.
Thank you. And I want to also support Don's comments about sort of not exempting everything and making the work, less meaningful. But the other point that I think is important is we could also be adjusting downwards for technology, because at least every tech pitch I've ever heard says they're going to reduce the cost of healthcare. But there are companies right now applying AI to radiology and diagnostics that are avoiding cascades of unnecessary services and improving outcomes, improving equity, and also reducing costs. So I think that we could be smarter about, hopefully we will apply a lens of value in technology adoption decisions. And so I just think I happen to agree with this recommendation that we should not make any adjustments now, but I do like your suggestion that perhaps in retrospect, if there were some, super exception, maybe we could apply it. But I don't think we should assume we're just sort of have a static system and everything's just going to add to the cost of it. We can change how we deliver healthcare and implement new technologies to enable better value.
Ian?
Yeah, likewise, I think, technology, the cost of technology is in how it's used, not inherent to the technology. The experience that sticks to my mind is 20 years ago when a new generation of thallium stress test machines came out, and when Provider Group purchased one of these, which I'm sure made a profound difference for a handful of patients, but this particular outlier provider wasn't just putting every single enrollee who was walking in the door, but their spouse on the machine and using it as a, as a way of ramping up revenue and many times over recouping the cost of that machine in a state where we don't have certificates of need or what have you. I completely agree with the recommendation here.
David?
Yes, thank you. Michael, I apologize. I missed what I know was an excellent presentation, but I did review the material. And I did have a comment, which I think just summarizes all the other discussion, which is that I think that it may be premature for us to not follow the recommendation on the table at this time, because we don't really know where this is going to go. I'd rather sit back and give it additional deliberation. I know that the history of medical care has been entirely based on a trajectory of new technology for decades. And I think our cost curves have been the product of that. I'd want to see some new impacts on that trajectory over time. But I think that we have the ability, fortunately, to go back and make some tweaks to our methodology as we go forward. And this may be an area where we want to consider it closely as time passes. And it's just fortunate we have that capacity.
Go ahead, Richard.
Thank you. And I just want to be sure we're not talking past each other as well, because the recommendation before us is that there's no adjustment to the value of the spending target to account for trends in the price of healthcare technologies. Now, in some ways, one can argue that and we're going to later talk about, we talked about 5-year trends, et cetera. And you did talk about, well, we can't predict the future. But I would also argue that, yes, we can't predict the future, but we also know what's been going on, right? And so I think that, and you're right, there's technologies that actually can raise and lower costs. Actually, frankly, we can get everyone to get their flu vaccine. We would actually lower, but that's behavior. That's not technology. The technology will lower the cost, but we can talk about the environment that is discouraging people from getting vaccinated. And frankly, if you look at what hospitals spend every winter, it's respiratory diseases, right? And if we all wore masks and got vaccinated, those could go down. We could spend less on healthcare, but people don't, and that's what happens. So I guess I would say is that. I guess my concern about this specific recommendation is not the literal words of the recommendation, but the lack of acknowledgement that perhaps, especially if we're going to talk about 3-5 years, which we'll talk about a little later, that we should every year look at what has changed in the technological space. And if there are, you have a Sovaldi, you have frankly, I'm looking at this gene therapy for sickle cell now. Well, it's still early. The FDA just approved it. I don't think we have to price in the exact price that whatever the manufacturer wants to, but I also think we need to acknowledge that people should have access to that at some point, at some level, right? I don't think I want to deny people with sickle cell essentially a treatment that for many of them is almost it's close to a cure, right? And that we're not going to acknowledge it. And actually, frankly, what we're sending the signals, we're discouraging people from providing coverage for that. That's the signal we're sending, right? And that I think would be wrong. And so, sorry, patients matter to me a lot. So that's what I'm concerned about. So the way this recommendation is framed, while it doesn't specifically say, I think we do need to look at particularly, what's going. There's sort of this baseline trend of technology that we've had for a very long time, major cross driver, right? It's probably kind of there's a little bit of baked in there, but even if we're looking at that, and I think Richard's brought a good point. We be sure we're not trying to squeeze that out too. But I think that we should look, because we are in this realm where we're having we do see these. This is not a Me Too thing where we already have something and it's another one that doesn't really add value. There are some things that are popping up that are actually frankly game changers, and that's comes from our investment in science and health research, right? And some of these game changer things we might want to think about how that
we build that in so that we don't discourage people from being offered those types of, or we penalize people who offer those types of treatments to people.
Yeah, I also just want to draw a distinction between a prospective adjustment versus a consideration of a cost if someone doesn't hit the spending growth target. So, we're all very, very concerned about patient care, and that's why we're here. And of course, because affordability is an adjustment, is a concern for patient care. So I think the staff recommendation is not to the board is to not make an adjustment on the front end because it is hard to predict, and that's different than understanding and looking at the data for an entity that doesn't meet the spending growth target. So just wanted to make that clarification.
So perhaps I would suggest an amendment to the recommendation is that the staff provide an annual analysis of technological advances or advanced by everyone, but sort of costs, and that targets be reviewed. So we don't just set a 5-year and leave it there, right? That we're actually looking at, are there any significant events? That's not only technology, by the way. I mean, if we had another COVID pandemic or something, God forbid, right? That that should be something that is not, that's a regular thing that we're doing, right? That the board's looking at.
And that is part of the staff recommendation as we go through the methodology, is that there be an annual review of the spending growth target and a look at the trend.
Including all those items that are in the statute that we should be looking at.
Would you then be looking at savers? I mean, so, the GLP-1s are supposed to save us a fortune in reduced costs of obesity. The AI is supposed to, exactly, well, and AI is supposed to save us a fortune because it's going to make primary care physicians spend 90% of their time with patients instead of doing all the administrative work that you were talking about, and it's going to decrease medical errors and so forth. I mean, it's one, complicated, I guess, and two, if we're going to do it, we should look comprehensively rather than at just the costers, and then we would also have to take into account the thing you're alluding to, which is the difference between what we should be paying for these things and what we are paying for these things.
Well, let's say yes, I think. And by the way, I said we're talking about things that are at scale where we're operating at a fairly large scale, being given the size of our economy and so forth. But those are things we should be looking at, right? Frankly, I don't see AI. Sorry, I did some research on AI and going way back when is really driving. Like to see the proof in the pudding there. But for example, I said I didn't bring this up the gene therapy for sickle cell because it might happen, right? FDA's actually approved it now, right? So it's not like, there's something, and there's a lot of hype about stuff. I get it. There's a lot of hype about stuff, but there is some point where it basically is now crossed over into, all right. So, I mean, we're not talking about looking at stuff that may happen. It's like now that we have an FDA approval, I mean, it's real, right? It's now we can argue whether there's some argument back and forth whether an FDA, but that at least that's one threshold where now obviously that's on the drug side or device side, right? But if so far I've not seen something show that AI has actually dropped healthcare costs. If they had some strong proof, I think maybe an ARC analysis, if someone knows something about ARC, that shows that, then maybe we should incorporate it.
So, couple of comments from me on this. First, Michael, I appreciate, Rick, your point. We can do anything in California, but what about other states? How have they dealt with this? I don't know that we brought that up, and I mean, if we don't know that today, I think it's worth talking through because we can't be the first ones grappling with this. I don't want to lose Elizabeth's, or one of her original points that, the costs are important, but what they might do, the totality of that technology's impact on costs maybe coming down in the aggregate, whether it's you pay a lot for a medication that then leads to reduced days of, ED visits or hospitalizations. How do we think about that holistically? The other place that this struck me probably because I spend a lot of time thinking about the impact of behavioral health on total costs. And, you know, when you talk to plans, they will say, well, we never really planned for this level of need in the behavioral health space. And even though the models don't exist today, you know, your definition of technology actually define like new models of care. I see that really needing to emerge in behavioral health. We're way behind. We don't have the workforce. We don't have the models. And that's going to lead to higher costs, right? We're going to have to pay for that. We're not paying for it today. So how, or so we're told we're not paying for it today. I think how we sort of bring together those drivers, the need that's driving new costs in healthcare as part of this. I mean, I think it falls under your broad technology definition as well. So what I take from this really rich conversation is we may not be prepared yet to really say, hey, this is how technology is going to impact it. But I see and hear an openness to, despite some other areas where we said, hey, let's not bring this sort of risk or stratification issue into our cost target immediately, that there's an openness to really charging the staff and the team to keep an eye on this and how we might build it into the future, and not today, but down the road. And I certainly would be interested in what other states that are a little further ahead of us in thinking through this have done with technology, and if that's available. You may already know.
I already know. So I have a three-part response: none, some, and all. So the none is that no other state or none of the other states have adjusted their target based on a projection of the impact of technology. Some of the other states have, however, and actually most of them have created some provision that allows them to revisit their spending target value if some trigger is tripped, and they define it differently. All of them anticipate and retain the ability to contextualize performance against a spending target for unexpected events, and 2020 and 2021 are the best example of that.
Okay. I don't know that we've totally resolved it. I hear general understanding and agreement of where the recommendation is. I know that we want to keep at it, but in order to move on, just sort of looking around, any hesitations? Yes. Yeah. Okay.
A little quibble on the wording, the price of healthcare technologies. I think what you mean is the expenditure on new health technologies, not just price per se, but price and volume together.
I think that's the relevant concept.
Yeah. And so I wouldn't call that price. I would call that expenditure. And yeah, maybe nothing more to add other than that wording quibble. When we get to
the reason we use
recommendation, maybe we can come back to this.
Okay. The reason we use price, Rick, is that's what's in the statute. But I think the concept that you all have been talking about is spending.
Well, let's at least amend this, because I think nods around on that point, right, Rick? Okay. Any final, please? No, you're good. Richard, I know you have more to say here, but avoiding the rabbit hole, appreciated. Elizabeth, anything more for the moment? No. Don? Okay. All right. Well, we have plenty of time for rabbit holes. Okay. The staff recommended that we're not as behind as I worried we were, that we take a short break. If we could just keep it to 5 minutes and then come back, I would appreciate it. We'll see you in just a moment.
Yeah, well, then you would actually know whether it's possible or not. I just know to ask the question. Oh, I can tell you here exactly. You're in.
Hate to be the taskmaster.
But, excuse me, the time is 2:55 and we'd like to reconvene the meeting now. Thank you for coming back to the table. We'll begin the meeting.
That'd be fun. Okay, Vishal. Thanks all for coming back close to on time. All right, Vishal, I think to you.
Yes.
Great.
So I'll be covering our preliminary proposal for the healthcare spending target. Next slide. Back one. I think the timeline slide. Okay. So we wanted to give the board and the public a sense of timing, that the purpose of this meeting is a preliminary proposal. It's not OCA's formal recommendation. So this meeting is we wanted to have that engagement with the board to get feedback and actually, place a number out there so we could get your reaction. And then in January, we would have a formal recommendation to the board on a proposed target. So we hope to post that around the 15th of the month. And the advisory committee this time is going to happen before the board meeting on the 23rd of January. So they would have a chance to weigh in, and we would bring that feedback to you all on the 24th, along with our, going over the proposed target. And then that would trigger a 45-day comment period that's required in statute from the January 24th board meeting. The 45 days is tied to a public meeting. So when we count 45 days, that'll bring us around March 8th, that lime green circle for the closing of the 45-day comment period. So, we have a February 28th board meeting as well for additional discussions on the proposed target and the board's reaction and considerations. And then once that March 8th 45-day period closes, the target could be adopted by the board anytime between March 9th and June 1st. June 1st would be the latest it could be adopted, but the board could certainly adopt it sooner if it chooses. Any questions on the timeline before I move on? Yeah.
March 27th.
March 27th is the meeting for March.
It's a clarification question. On the January 24th meeting, board discusses proposed target, board votes on proposed target?
No. The board can't vote on it until the 45-day comment period closes, which is in March. So after March 8th.
So the proposed target is a proposal of staff, not a proposal of the board. Thank you. Seems surprising to me, given that the board is eventually going to adopt a target, but I'm not a parliamentarian, so if you tell me that's how it works, I'll believe you, I guess.
I think that's what they're saying. That's the way it is.
That's what's in the statute.
Yeah.
The staff proposes and then the board adopts.
Yeah.
Yes. After that, but we do have to have that 45-day comment period.
Next slide. So just want to give some context on the proposal. We during the October board meeting, we considered a design question specific to the target values. The board members voiced their preferences. Today, informed by that input we received in October, the feedback we got from the advisory committee in November, we propose a methodology and a target value for the statewide spending target. We'll present some of the elements, including the target values and related methodology, and then we'll review the underlying design proposal, including the rationale, and we'll seek your input. Next slide. So this is just a reminder. We've shown similar versions of this slide. It's from other states. You know, some of them have a target value for their first year, and then they, you know, some of them phase it in. Some of them have a fixed value for a number of years. So this is just to show you that, you know, the range of target values, and some of them do go below 3 for some states, and then in the low to mid 3s for others. Rhode Island does have some variation in their target for 2023, but for out years, they also have different numbers. Next slide. So OCA's preliminary proposal is that adoption is to adopt proposal is the following statewide per capita healthcare spending targets for 2025 through 2029. So that would be a 5-year period for the targets. And then it would be based on a weighted average of historical median household income growth over the 20-year period from 2002 through 2021. So that would be a 3% target value for a 5-year period. And then in the next slide, we'll go over kind of.
Can I have a technical question?
Sure.
I know the first year, so because the recommendations for 5 years, the first year's quote not enforceable, but
yes,
subsequent years are, right?
Yes.
So essentially the subsequent years all are enforceable.
Yeah, 2025 is a performance year. We'll still collect data and report on performance, but it wouldn't be subject to the enforcement.
Right, but you're proposing essentially the 7 enforceable ones as well, because you're suggesting 5 years. Okay.
Yes.
Just want to clarify.
Yeah. And then this slide just goes over some background on trends in median household income. So the 2008, it shows the graph on the left shows a trend for that 20-year period. You'll see a lot of ups and downs, you know, with certain years. So the 2008 financial crisis was associated with large decreases in median household income. So those years have an undue influence on the unweighted average across the 20-year time series. And then if we were to assign less weight to the 10-year period from 2002 to 2011 and more weight to the 10-year period from 2012 through 2021, median household income steadily increases. So the chart on the right with the bars, it's essentially the 2.8% is the unweighted average for that 20-year period. Yes, board member Mitchell. Oh, okay. So the first bar is a 2.8%. It's an average of the 2002 to 2021 period. And then if we were to weight the periods differently, basically dividing that period in half and then applying different weights to each one, we could get a higher target value. So if we were, and the thinking behind that is that we're applying more weight to the more recent past. So if we were to do a 55-45 weight, it would result in a 3% target, which is what we're recommending. And we included the other bars just in case if we, just to show the board to give you a sense that if we were to weight the more recent past, give it a higher weight, it would result in a higher target percentage value. And I do want to note that the reason we're focusing on this period is 2002 to 2021 is that we also have personal healthcare expenditure data from CMS for that same period where we're able to trend California healthcare spending. But I do want to note that 2022 data is available, and just to align the data sets with the same years, it's not on this graph, but I could report that value, which is in 2022, median household income grew by 4.6%. So there's always going to be changes, and we don't know what the inflation is abating, but we don't know, we won't know what 2023's value is quite yet. Just wanted to flag that. And then I see, Rick, you had a question?
I mean, the 20 years seems like a pretty arbitrary period. And, we've got the 2008 recession in there. Obviously, we might have another recession in the next 5 years, but it's not what most people are anticipating. And I don't understand. Can you explain why you chose a 20-year period rather than, say, a 10-year period, which would have avoided including that last recession in it?
Yeah, we'd also flagged that 2019 was also kind of a boom year, and it does, have a household median income grew by more than 10%. So there's always going to be fluctuations in the data. We just we focused on a 20-year period. It's a longer time stretch, and we could always apply different weights to give more value to the more recent past.
Is there a standard, would you say, in this?
Not that I know of.
Because 10 years is.
But 10 years feels like a pretty good stretch of time. Okay. But I'm not aware of a standard.
Yeah.
I think part of the 20 years also came from we were looking at 20 years worth of historical healthcare expenditures, and we also note that, affordability is compounded over a person's lifetime and over a longer time horizon than just what they've experienced in the last 5 or say 10 years too. And so I think that was part of where we were just, and in our initial discussions, we started with 20 years, and it seemed to give us that long enough historical look back where we could make some of these adjustments to look at the data with discerning eyes.
Yeah, I think just equal to the question of what's the timeline you're looking over, what is the right weighting? I think you could ask the same sort of question around that as well.
With the potential for weighting it, say, 100-0. 100 to the last 10 years and 0 for the 10 years before that.
Certainly. Okay. Looks like lots of is this. We're gonna pause for a round of questions. Richard, then David, then Elizabeth. I saw hands up, and then we'll come back to Ian. All right.
So first of all, I think we need to acknowledge that the Great Recession was actually the largest economic recession since the Great Depression. Right? It wasn't a typical recession even. We also have COVID. The last time we had a pandemic of this size was back in 1918. So we've had 2 kind of century type events in the last 12, 15 years. Now, maybe they'll happen more frequently. I don't know, but so in some senses, there's a little bit of a combination of unusual events that have happened recently. And again, I'm not an economist, but But to me, especially since we're looking at 5-year projections, what I'd almost like to see is I'd like to take a 5-year running average and see what the variation is. So 22. Actually, I think we have data on 2022, don't we? The 2021 is the most recent.
We do have 2022.
Okay, well, then let's start with 2020. Yeah, let's start with 20. All right, let's not ignore 2022 and go back 5 years, what the average is there, and then go 2021, take the 5 years and see what the variation is up and down, because after all, we're doing 5-year projections. We might as well see what the variation is and what the median, what the average is of that, of a 5-year running average of every 5-year period, right? And let's see what that line looks like, because that sort of evens things out a little bit, right? Having a trailing. So that might help us have a better sense of like what the variation is in median income over any 5-year period. And again, we have 2 century events in the middle, right? And it's averaging, so it's not probably quite as bumpy. It'll smooth it out, but at least that gives us, I think, a better sense of that versus just taking 20 years and then just averaging it out over all 20 years. With again 2 century size events in there, why 20 years? Oh, because we have data on healthcare expenditure for 20 years. That's, to me, not exactly the best reason to pick that time, especially since you're including 2 very exceptional events economically, as well as healthcare wise, in that period. That the prior time something of that scale had happened was almost a century ago.
David?
Yeah, my comment was going to be similar. We have these, there are a variety of ways to smooth these trends. And yeah, we do have two outlier events that have occurred, which is very unusual within a 10-year period. One is up, one is down, of course. Maybe they've washed each other out. Yeah. So I think there are a variety of ways to deal with the longitudinal data. The actual question that I had was another why question. It's actually the one that Rick just asked, which is why did we pick the 3.0 number instead of a 3 point whatever number, 70-30, 80-20, 100-0? That's a pretty arbitrary decision. I know that it works in the direction of perhaps increased affordability, but any of those numbers could have worked. And I'm just wondering what the rationale was for the 3.0 number, the 55-45 split.
I guess speaking exceedingly plainly, I don't know that there's a perfect methodology that's going to get us to a number, so much as we can try to our best extent to make adjustments for events that we witness. Like when we looked at the data, we witnessed a rise in 19 of more than 10%. We know that we also saw that we lived through the Great Recession. And so it was our attempt to kind of foment this discussion where we come and land at a figure, because we know that I think we heard from our advisory committee, like one of the most important things that we're going to do in this is actually just picking a number, whether the value's 2.9 or 3.1. And we also know that some members also said, hey, every 1/10% matters. I think that this is also an acknowledgement that there's not necessarily a golden method that's going to enlighten us to the path of the perfect figure. I'm speaking, I guess I should say, I'm saying that as behalf of me, and I don't know that I want to bring H. Kayanoka into that with me, but I think that if I'm speaking plainly, I think that that's we grappled with how do we come up with the best figure while keeping in mind the realities of the costs of the healthcare industry, patient access, patient affordability, and really trying to balance all of these different interests to land at our initial stake at here's a measure that we need to lead around and march towards.
I guess, I agree. I don't dislike the 3.0 number because I think it speaks more toward affordability. But for a first time step or decision, there's a rationale for being maybe more conservative, especially in the face of more recent data also that might drive this number up higher based on the 2022 data that we have. Just a question, it's kind of an arbitrary decision.
I think part of the conversation that I hope we're going to have is acknowledge where there's a choice being made, right? There's not a perfect science to drive that choice or a history of other people's practices to drive that choice. Yet we're making a choice that we've had a chance to dialogue about kind of the uncertainty or wouldn't say randomness, but certainly the choice element here and leaning towards, either quote more conservative or more liberal, depending on how you want to look at it.
Statistically speaking.
Yeah, exactly. All right, Elizabeth, and then I'm going to come over here, and then I'll come back to you, Richard. Go ahead.
Thank you. And I just want to focus on another choice, which is the fact that we are actually suggesting that in 5 years, it would be fine if healthcare costs 15% more than it does today. That's not even thinking about the compounding effect. And I understood that we're here to address affordability. We learned at a member event last week that over their lifetime, half of a millennial's earnings will go into healthcare. And what we're saying right here is that it's fine that any increase in household income basically go to the healthcare system. So if I wanted to, as you know, include median income, but not necessarily just give it all back to healthcare. So I just really am concerned that this is being considered sort of conservative when we are hearing people now cannot afford healthcare. That is an equity issue on its own. It is an access issue. It's hurting businesses. So I just would like to reorient somewhat, at least for me, and think about, is it acceptable to say that any increase in household income goes into healthcare, and that 15% increase in 5 years is, equates with affordability? And I appreciate that's not exactly what we're saying, but it's suggesting that.
We're all going to circle around these, so I'll come back. Rick, Ian, go ahead.
Yeah, just to address a couple of these points. I mean, on the Great Recession, maybe it's a once in a lifetime thing, but there's a lot of those happening these days. It's fresh on my mind because that was a period where people's incomes were going down, but health plan premiums were going up between 10 and 15% a year, similar to what they're doing today. I appreciate acknowledging that what we're picking a number, and there's a degree of arbitrariness here. Just to put a fine point on it, back of the envelope math, every 0.2% that we're talking about here over a 5-year period means spending another $25 billion out of Californians' pockets that is not going into housing, that is not going into the other essentials of life. I think the question that comes back to me, especially if we're going to consider shorter time horizons and less smoothing, is back to the definition of cost growth here. I think it was after the last meeting, a member of the public pulled me aside and explained her understanding that cost growth cannot be negative, and I'm still puzzled why that can be. But if we're going to look at shorter time horizons, why isn't this potentially a negative number?
The statute doesn't allow the board to set a negative spending growth target. It could be a 0.1, but it can't be negative.
Mm-hmm. But not to gloss over your point, right? Which is, why is this going, and Elizabeth, I think part of your point, it's going this way always, not this way or that way. Okay, Rick, I think you're up.
A point of clarification, Elizabeth. If median family income goes up at 3% and health spending goes up at 3%, the median family will have kind of 82% of the additional money for things other than healthcare. Healthcare is about 18% of total spending, and so 18% of the growth in family income will go to healthcare. 82% will be available for other things.
I appreciate that. I just think that we're tying this awfully closely.
Come back to you, Richard.
Yeah.
this is actually follow up on David's comment. I think certainly one of the things I don't want to be accused of is picking a target and then trying to go backwards to explain it. So, and so basically, oh, well, we picked a target and we're trying to come up with a rationale for it, and we made certain. So I think, you know, I'm just a little concerned, like, oh, well, actually, you know, why 55-45, right, et cetera. So I think we need to have a sounder rationale for the decisions that we make. For example, if we're doing 5-year horizon, that's just it. Let's look at 5-year trailings or something. So because we're working at 5 years, but I think there needs to be a little more internal consistency of the rationale with what we're doing. And I'm not, again, back to the why 20 years, why 10, why not, et cetera, right? And again, you know, I would point out that, and actually, interestingly enough, appreciating what you said, but you know, healthcare demand, unfortunately, doesn't go down. In fact, it probably goes up when the economy goes down. You know, we have this counter-cyclical problem too. So, you know, I think that's something we've got to, in terms of, let's just not only think of healthcare expenditure, just healthcare needs, right? What people going to need for healthcare doesn't automatically go down when the economy goes down, right? And so, and by the way, the other point, everyone keeps pointing to 2019. So, you know, I said we have a Great Recession that was, you know, we know that that's the largest since the Great Depression. We have COVID, which we know is probably the biggest. I think, you know, to simply write off 2019, like, oh, wow, it's a big year, but is there something that happened that year that is unusual that you'd point to other than the number being higher? I mean, if there, so I'd be interested in knowing, you know, when people talk about 2019, was there some event that happened in 2019 that particularly stands out that makes it an unusual year for that, other than the fact that the number that number went up? And by the way, you know, I think median there's a lot of different factors that go in. That's not just, you know, and so one of the challenges is going to be is we're trying to put a cap on healthcare. All right, we're trying to put a cost target, but, you know, depending on which administration's in, what kind of other policies that are pursued, that could affect, you know, median income. But for example, 2019, if there's something that unusual that happened that year to make us have to say that that's something that is a one-time event, and therefore then I'd feel a little, but I'm not sure I'd say, oh, let's try to find a way to dilute out 2019 unless you have some reason to explain that that made a particularly unusual year economically.
Okay, I want to keep the conversation going because I think it's a rich one. But in the spirit of what you just offered, Richard, I think part of the feedback I expect out of the board to the team is, okay, they presented something.
So what I'd like to do is I'd like to have a 5-year trailing average. I'd like to see what the variation is over, you want to do it over your 20 years, that's fine. I think that gives us a better sense of where, since we're doing 5-year forward projections, what sort of that variation is, and at least to give us an upper, you know, that gives us some bounds as to what that of what happens in 5-year periods.
And I heard one other thing, which is even in that exercise, I would be concerned, given your comment, that there's still a little bit of, well, we just chose this, or we looked at this and we've that hopefully we can sort of explain a little bit how we handle the outliers a bit, or how we consider that piece.
Well, and again, we should explain what the outliers are. So if, again, back to what makes 2019 an outlier, right? I can explain, I think we can argue 2000, 2011, there's an outlier there. There's an outlier event that happened, right? We asked into 2020, there's an outlier event that happened. If you want to say 2019 is an outlier, that's fine. Explain to me why that's an outlier.
Okay, other thoughts on this or other?
You asked earlier whether there's, you know, sort of a standard practice of using 10 years or versus 20 years, and I said no, and I'm not aware of one. But sort of looking at these data, it does look like the last 10 years are different than the 10 years before that. You know, you just sort of look at them, they're at a different, they're kind of centered. It's not just the recession, even aside from the recession, they look like they're centered in a somewhat different place. And, you know, I don't know what the next 5 years are going to look like, but it makes more sense to me that they're going to look closer to the last 10 than the last 20. And I'm not an economist. I don't think any of us are economists. I'm probably closest to one. I play one on TV occasionally. But I think there is some argument, some reasonable argument to say if we're trying to figure out the next 5 years and we're not using projections, but we're using history, that we should look at, you know, 10 years is not just recent history. It's still, you know, it's a fairly long period of time. It's not high science, but it's not completely arbitrary.
Well, I think out of today's conversation is certainly going to be a set of, you know, hey, let's consider it in different ways and look at it that way. I think to the point about what the legislation requires this body to do, it's one of the key things we're going to do is adopt this, you know, cost target and set it. So we should take the amount of time we need to get it right, or as right as we can. Don?
I was just gonna say, you know, I think that I have no idea what the right number is. I don't think anybody in this room has any idea what the right number is. The question, it really is more like how much pressure are we applying to the healthcare system, and what do we feel comfortable applying to the healthcare system to keep costs down and to avoid unintended consequences for patients, right? That's what everybody is nervous about on the back end, and that's what everybody wants on the front end. And but dancing around, sort of like picking a magic number as if it's grounded in something that makes sense, I don't know that that's, you know, it's pretty close to a lot of the numbers I'm seeing coming out of other states. But you know, and it, you know, it's this here is kind of a Rorschach test, and I just I think that's the better conversation to be having. I don't know that we have consensus about what the right amount of pressure to apply to the healthcare system is. But I think we wouldn't be here if it was zero. And so I think the question is, how much can you apply without having it do harm? And I would add that as we're having that conversation, we need to factor in all of these other considerations, like what high healthcare costs do to people also, which is really important.
Well, that I would say is part of the harm.
Right.
Yeah. Okay.
Can I offer something?
Yeah, please.
Okay. Two things. One is the spike in 2019 might be a data problem because it was collected in February and March of 2020, and the response rates were low, historically low. California's rate of increase was higher than the nation, but overall nationally it was up. And one hypothesis is it was incomplete data collection. In addition to that, I want to make a suggestion to move forward. I personally think looking back more years is sound, but there's a recession sitting right in the middle, and there's an aberrant figure for 2019. So I want to suggest considering a smoothing approach that adjusts for the recession, which clearly drags down the rate, and also accounting for the suspicious 2019 figure. I think that would give you a sounder historical look back.
We'll add that to the list of things the team considers. Richard.
Well, I think Don just brought up, whether I agree with him or not, a fundamental question, right? Because we're all talking, we talked last time about, median household income. We brought that to the advisory committee, et cetera, right? Are we planning to base it on some measure related to that, perhaps correcting for if there's statistical flaws or outlier events and so forth, or should we just, but if we're honestly, if what we want is just pick a number that puts pressure on the healthcare system, then let's strip the pretense and say that's what we're out to do. So which one is it? Are we trying to tie it to median household income in some way with whatever rationales we make to make adjustments to that for that number to best reflect? I think our discussion before was how to make it better reflect the historical, because we're trying to look forward, how to make, what sort of historical issues when we look back, et cetera. Or do we just say that, well, actually, that's not really what we're trying to do. We're just using that as a proxy for trying to do what Don's saying. So, I mean, I think we should be honest with people. Which one is it?
Elizabeth.
Yeah, just on that point, I understand that the reason we were considering household income is because this is about affordability, not just the inputs into the healthcare system. And that is some proxy for what people can actually afford to pay. So I do think it's important. I don't think our task is an actuarial forecast. I think our task is to use judgment to identify some number that will improve affordability while, as we all are committed to doing, maintaining or actually improving, hopefully, quality and access and equity.
Rick?
I would answer Richard both. I mean, and as Elizabeth said, that we want to be paying attention, and North Star is paying attention to affordability. And I think we all agree that median household income is a good metric to be looking at when we're thinking about affordability. In my mind, that doesn't necessarily mean that health spending should grow at median family income plus zero. And in thinking about whether it should be plus zero or minus some number, as Elizabeth might suggest, or plus some number, as I might suggest, I think, making some judgment about the amount of pressure that it makes sense, that it's feasible to put onto the healthcare system is the kind of balancing act. And so I wouldn't, say that we should only look at affordability or only look at pressure. We want to be looking at both.
Other people want to jump in? Okay, is this a healthy place to move on, or do you feel so much has been said, and I think a lot of rich advice on how to refine, in particular, this slide. And I don't want to, Don, I thought you summarized the conundrum challenge here pretty well. Like, are we backing into a level of pressure or that we feel comfortable putting on the systems, or are we actually going to drive like a really well refined number? And I think more than anything, I would like to get out of this some real direction for the team to feel like, hey, they have some next steps. I heard something out of Michael. I think, Richard, you provided an approach with some, I think, Rick, you provided some ideas worth kind of refining this. And I think some, not defense, but more justification if we end up back at, hey, we did all these things, we're still at 3, to explain that a bit. Vishal, do you have, you jump in there?
Yeah,
I see that smile.
That was a good segue. So we have OCA staff actively running the model that was used to calculate these figures. And if we were to omit 2009 and 10 and 2019, the unweighted average from 2002 to 21 would be 2.98% or 3% roughly.
I think you need to omit 9, 10, 11.
You're saying 2011 as well?
And 8 probably.
Yeah, and right.
Maybe not so clearly.
My advice would be we don't do this on the fly.
Right.
Right. I appreciate how quickly people can do the work, but let's.
Yeah. So a couple of things.
This.
Yeah. First of all, 2022 you have the number of 2022? We should have 20. I'm not sure why we stopped at 2021. So maybe you didn't have 2022 when we put the slide together, but we should include 2022 then. And I think what Rick said about, there's again, why 20 years? Why, versus 10? I think that there does seem to be a little difference. Again, there's an event that happened in the middle. It wasn't just a 2-year event. Anyone who did the state budget knew that. 2019, I guess there was a data thing. 2020 was so COVID that drove it down. Anyway, I think we need to see. I think we would certainly like to see a 10-year analysis. So,
but I understand I'm not objecting to getting data points and so forth, but cutting out big swaths of these time periods that were life-changing for many people. I mean, are we also going to claw back the hundreds of dollars out of people's pockets that went to health plan increases in those years? I mean, we absorbed those huge increases during that period that incomes were going down. How are we going to somehow pretend that didn't happen as well? It just doesn't make sense to me.
We could add an adjustment for a decade of overspending on healthcare.
Yeah.
I mean, that I think kind of returns back to Don's point in many ways, in my view, and I thought it was a really well stated point that we're going to have to grapple with. So we buy a little time with some of this analysis, but I think this is certainly going to be something in our next meeting we're going to have to dig into a bit. Okay. As you guys, CJ, is it your turn?
Yeah.
Okay.
So just a couple of slides to kind of put this into context around what 3% would mean and how this kind of compares with personal healthcare expenditure per capita growth that we've witnessed over the last 20 years. And I'll note that the reason that we have not included the 2022 is because the 2002 to 2021 is where we just have comparable time series data. That's what's led us to where we are. We certainly can come back and add 2022. Which I think had a growth rate of roughly 4.5%. Between 2002 and 2021, the personal healthcare spending grew cumulatively by 163%, while median household income grew at 72%. So this is, again, just for illustration's sake, had healthcare spending grown over that same period at a rate of 3% per annum, then it would have tracked more closely with the rate of growth in median household income. A couple other points that we just put together for illustration's sake, showing what would happen to personal or potential savings in per capita spending. Had we, using the 3% and then comparing this based off of CMS forecasted data, what would be the differences in total spending and the differences in per capita spending? Lots of caveats around this. This is just an illustrative model. We are, and we know that when we set a target that spending is not just going to miraculously go to 3% overnight, but assuming that there was perfect fidelity with the model, this is what one could expect in terms of savings in per capita healthcare spending. So over the course of the next 5 years, we would get to a place where we would be realizing rates of savings of upwards or close to $1,500 per capita in spending at the end of 2029. And you can see how that phases in year over year as healthcare spending would be slowed relative to what CMS projects. Similarly, with aggregate healthcare spending, we're talking about differences in savings. If a 3% target were achieved, we would expect to realize savings of $81.6 billion in 2029. So, the impacts of this, I think, at both a personal level and an aggregate level, this is to illustrate what could happen were the targets implemented at these different rates. Back over to Michelle.
I'll just quickly go through this. So the preliminary proposal is to establish a statewide target that is lower than the long-term healthcare spending growth rate fixed target for 5 years, and we recommend it be tied to the average household median income. Do not adjust for population-based measures, and then we do suggest that the board evaluate the target annually for potential adjustments. Next slide. And then for the economic indicator, OCA's preliminary proposal ties the target to a historical median income based on the last 20 years, basing it on the target on this measure of consumer affordability signals that spending on healthcare should not grow faster or take up a greater proportion of income of Californians than it currently does. A single economic indicator promotes transparency and public accessibility. Using historical data reflects long-term patterns and does not rely upon uncertain forecasting. And then using a weighted average treats more recent years as more informative. And given, we've had a lot of discussion on these items, I'm going to move on to the next slide. As part of our methodology, the preliminary proposal is not to make population-based adjustments. OCA found adjustments based on population-based measures, including age, sex, disability, chronic condition, prevalence, as we showed some analysis at the October meeting, appear to be small. And there's also the problem of confounding variables with one another and other economic indicators. OCA also found that the data was limited to forecast the impact of population-based indicators on future spending growth. Next slide. Just to highlight the bolded bullet on the right, the statute does call for the target to be updated periodically and consider relevant adjustment factors. Next slide. So in the statute, the board has the authority to revisit the target, to update it periodically and consider any relevant adjustment factors. So our preliminary proposal, if the board commits to evaluating the target for potential adjustments on an annual basis. And that wraps up our overview of the preliminary proposal.
Okay, come back, Richard.
I would strongly disagree with not making population-based adjustments. We're doing a 5-year projection. We'll do projections beyond that. We know the population's shifting. The population of California is aging. That increases demand for healthcare. So you may say it's small, but you just pointed out earlier that small numbers add up. We do know the population shifting in the state. So I think that, you mentioned there certainly perhaps some confounding between, let's say, age, disability, and so forth, but I think there needs to be some adjustment, at minimum adjustment for population. The other question is, and the reason I asked about enforcement is that, so now we pick a target, first year we don't enforce, now we have subsequent targets we will approve that are going to be enforced. So how are we going to go about enforcing those, right? Are we going to go to a healthcare entity and say, well, you're above 3%, right? And and that's where perhaps on a statewide basis, adjusting for disease, chronic, risk adjustment doesn't matter, but it does start to matter when you're starting to go down on the enforcement level, right? We don't want to punish people who are taking on more people with chronic diseases, right? That will discourage, that would be horrible for people with chronic diseases, that basically entities said, well, guess what? The real option is to take so many healthy people and definitely don't take care of anybody who has chronic conditions. So we don't want to create that adverse incentive that's already built into our healthcare system, make it worse. All right. So actually, when we're talking about collecting data on the TME, I mean, I think it would be important to be sure we get enough data to be able to do risk adjustment when we need to do it. I will also point out that in the statute, we talk about risk adjustment, and it's in the statute, as well as equity adjustment. Because I know some people have expressed concerns, oh, well, it's an equity issue that we're actually doing risk adjustment. Actually, it's an equity issue not to do risk adjustment. And the reason we put the equity adjuster is, yes, we do recognize that perhaps someone who's lower income, by the way, we do have a Medi-Cal program to try to improve access to healthcare for people, that they may not see a doctor as much. And so therefore, you may not have and that's because risk adjustment, if you do risk adjustment just using billing codes, yes, that becomes a problem. But we can factor that in. But what we don't want to do is create disincentive for people to see people with chronic conditions. That includes mental health, by the way. So talk about behavioral health, right? Behavioral health, for the most part, is chronic. That we don't really have a treatment to make it just go away. So, I am concerned that we're not doing adjusters. And so I get it for a statewide target. Okay. For risk adjustment, but when we start talking about enforcement and what we're going to enforce onto entities, I think we do have to factor in what type of risk profile that entity is taking on. And so we should have the data to look at, are they an outlier or not when it comes to risk? Are they an outlier simply on costs? In which case, of course, we should try to okay, well, that's not acceptable, right? So a lot of our discussion has been framed around the statewide target in the first year, but we're proposing a 5-year target. And we're also, hopefully in 5 years, not just talking statewide targets, we're starting to do some of the other parts. And I'm glad to know we are collecting data on geographic differences because, again, unlike some of the other states, we're a very big state with a very varied economy with lots of different things. So hopefully, actually, even as we're doing a statewide target, because we know which covered California region or LA, that we're actually going to be able to look at the different areas and see what the variations are, because I don't want to punish someone because they're in the wrong part of the state, right? As well. So that backs down to the enforcement part, because you're proposing eventually to say we want to do 5 years, and in those years are years that we are going to do enforcement. And so it's going to be very important to know exactly how these numbers are going to be applied to particular entities, because there's enforcement attached to it. And so that, to me, that's a concern. So a lot of our initial discussions well, these are just targets. Well, I think, that we did put teeth into this legislation. I want to be sure those teeth are used appropriately and not creating disincentives for people.
Don, go ahead.
Just to kind of come back to this question about the target rate, I think it would also be helpful if we are also trying to get a sense of the impact on health system to, a lot of these states are kind of right around 3%, seeing the experience there. I'm looking, as I look over these numbers, super interesting that most of them have lowered their target year over year. So they started with a higher number and they've come down, it looks like. I'm guessing that may be because they've come to a conclusion that there's more tolerance for lower spending growth targets than they had originally thought, but I have no idea.
That might be the phase-in.
Is that phase-in?
I don't know for sure, but I think some.
So
Michael's
those were
nodding.
intended to come
So
down
they
over time.
sort of gradual,
then
which we
yeah.
had discussion about in the past.
But it would be super interesting to kind of hear experience there. And also, I keep on thinking back to these early presentations from other states where they're reporting back that it's sort of too early to tell whether they're actually saving money. That's another consideration. So as we're looking at these targets and trying to figure out what their intent, I would, or their consequences are, I think it's important that we look at both sides of that in their experience.
Good flags. David, Elizabeth, Rick. We'll all get a turn.
I find the discussion to be very interesting, and I think one of the challenges here is going to be actually presenting our methodology and our thinking to others externally as well. I'm more comfortable, I think, with where we are on risk adjustment. I was particularly taken by the statement that our demographic, age, gender adjuster, disability status, prevalence of chronic conditions are correlated with each other, which suggests that one could really do the job of them all. And I think the best one from a methodologic standpoint is age and gender, if we wanted to pick one. I also note the statement about the impact of all these being relatively small. So I'm very happy with a methodology that has some risk adjustment, and maybe the one that we started out with originally, age and gender, is probably the best one to use.
Thank you. Elizabeth, go ahead.
I would agree with that, just using age and gender, because again, it's about affordability. But the bigger point that I would like to make sure we consider is this presumes change in the healthcare system, and we have been doing multiple pilots over years with our members, and we are doing one right now in Arizona where bigger investment in primary care with integrated behavioral health and quality-based referrals is saving 14% total cost within 12 months. We did a Centers of Excellence network using top quality specialists for several of our members. They saved 50% total cost and got better outcomes, better access, better experience, all the things. So we will absolutely have to make changes, but the savings are achievable while also improving care. And to quote one of my predecessors, who you all know, we should not be applying a poverty of ambition when we think about the changes that are possible. And if they're possible on a small scale, I'm sure with the sort of wisdom and experience in this room, they're possible on a larger scale. So I think we need to presume changes, but we can achieve more even by spending less.
I think Rick, yeah.
I agree completely with Elizabeth that we can achieve more by spending less in theory. And in practice, I'm not so sure that the 8 of us on the board have much ability to accomplish at a large scale any particular changes in the healthcare system. Right? We're at a 50,000 foot level, and we can provide information, and we can provide the lever of if people overspend, there are consequences. But we're not managing, obviously, any organization and not going to be implementing the changes. Two requests. I think Don expressed quite eloquently, and Richard brought up, what are we trying to do here? Is it we're just looking at affordability, or we're trying to get to some number about how much pressure we think it's okay to put on the healthcare system? And I would argue, we should be doing both. We have some good information on affordability. We've talked about 10 years versus 20 years, but we'll sort of make progress. The request would be for some additional information about how much pressure are we putting on the healthcare system. And the graphs that you've shown, CJ, are helpful. 2 additional requests. One, a graph that would show health spending as a share of GDP or GSP under the projected status quo, and that same line with the projected either 3% or other estimates that we might come up with if we were to use the smoothing approach that Michael suggested, or the 10-year approach that I've suggested. And second, and maybe a little bit harder, but to take on the assumption that the slowing in healthcare spending growth will likely come mostly from a slowing in the rate of growth of how many people work in healthcare, because a large fraction of what we spend is on labor, although some of it is on prescription drugs and other things that are not labor. But if we took the labor share of healthcare and were to assume that that share wasn't going to change much, what would these slowdowns in the rate of growth of spending imply for the numbers of people working in healthcare over the next 5 or 10 years? You know, I'm assuming in that wages, salaries are not going to change. We don't want salaries to go down. We've talked about that a bunch. And given that people in healthcare are in a national labor market, it's probably not possible for salaries to go down much and maintain the labor force that we want. So if salaries aren't going to go down much, it's probably mostly going to come, slowdowns in the rate of spending growth will mostly come from slowdowns in the rate of number of people working in healthcare. And I think that that's certainly possible and consistent with improving quality, improving equity. But if we're trying to understand, to Don's earlier point and to Richard's point, sort of how much pressure seems okay, it'd be useful for me at least to have some understanding of how much pressure 3% or 2.5% or 3.5% would be creating. And I think these metrics would be helpful in getting some understanding of how much pressure, you know, various rates of increase would be creating.
Can I, Ian, before you go, just clarify, Rick, are you asking what is the outcome of the pressure?
Yes.
Okay. Like just if
we've seen a little bit of that in the slides that CJ presented. You know, he showed that spending would be $1,500 less per person in 5 years, so about 10% less, about 2% a year. And that's, I think, a useful sort of thing to know. 10% lower spending, $1,500, that kind of gives me some sense of pressure. I think, and I think at least some of my colleagues often think of spending as a share of gross product as a really important metric that we track both domestically. You know, we've been on this unprecedented 12 years of health spending flat as a share of GDP since 2010. I mean, a big spike in 2020, but then came back down. Be useful, I think, to know with a 3% growth rate or a 2.5% growth rate or 3.5% growth rate, what would health spending be as a share of GDP over the next 5 years? And I know we're setting a 5-year target, but more useful might be to also carry this out for 10 years to kind of say, if we were to continue this, where would we be? So health spending as a share of GDP would be helpful, and something about the labor force, I think, would be helpful.
Just to clarify on the labor force, do you mean at what level of pressure does it translate into changes in the labor force?
No, I think at any level of pressure, it's going to translate into some changes, but just to understand how big are those changes?
Okay.
Be how many fewer people will be working in healthcare in 5 years at a 3% growth rate than at the status quo growth rate?
Mm-hmm.
And how would that be different if we were at 3.5 or 2.5 or 4?
Just so the assignments are super clear, I want to give staff just a clarification.
Yeah, I think we may follow up with you, Rick. I don't think we're assuming that a 3% spending growth target leads to fewer folks in the workplace, in the healthcare workforce. So, but I'm assuming you'd be willing to follow up with us to talk about what kind of modeling you're looking for.
I wonder where else the money is coming out of. I mean, prescription drugs, some, and it may be coming out of administrative folks in the healthcare workforce. So when I say healthcare workforce, I'm including administrative folks.
Okay, because I just think we'll have to understand how we may be able to model that. I don't know if CJ or Vishal has other questions, but maybe just best to follow up with you offline. Okay.
This will be an important, I think, important conversation. Okay, I'm going to come back to the right side after Ian has his chance to jump in.
Yeah, I think Elizabeth just made the most eloquent call to leadership I think I've heard all year, and I'm loath to speak out because I've seen where payers are motivated, the opportunity to find huge percentage savings and improvements in quality. I saw that firsthand in Vegas years ago. But all this talk about percentages, and especially in relation to GDP, which has little bearing to affordability because it has little bearing to people's incomes. I appreciate the slide on page 84 here that breaks these projections down into dollar terms. You know, $1,500 per person per year for a household of 3. That's the difference between a 1-bedroom and a 2-bedroom apartment, right? Those are very tangible numbers, and those are really important both for us to make our decisions and for the public to understand what we're thinking. And I think that has to be the reference point as we're moving forward. So,
go ahead, Richard.
Thank you. First of all, I too would be very interested in looking at the labor data, particularly looking at what percentage of, when you look at healthcare, spend, exactly what percentage of that is labor and how fast the labor part has grown compared to the total, right? Is it at the same rate? Is the non-labor part growing faster, et cetera? So I think that would be very interesting to look at. I actually am also interested in we talked about the median household growth, and I've talked about maybe looking at trailing, 5-year trailing, whatever, but it'd be interesting to also look at healthcare spend too in the same way and see what the correlation is between two. Probably isn't much, but again, are they countercyclical, et cetera? So that's something. I appreciate what Elizabeth said. Interesting enough, when I first chaired the Assembly Health Committee about over 12 years ago, I think 12 years ago at this point, or 13, I started off with a hearing on actually innovations around essentially advanced primary care, medical home, et cetera. And we had pages and pages of pilots that showed decreased costs, lower utilization, improved outcomes, et cetera. And the question was, why didn't it happen? Why aren't people taking these to scale? And I appreciate another pilot. So why isn't it taken to scale? After all, you think hey, if I have the secret sauce, what's stopping me from doing it? After all, I can make a lot of money actually even doing it if it really worked at scale. And the challenge is that the problem is that right now we have a system that disincentivizes care of chronic disease. And so the problem is you now create something that, hey, guess what? That's a great place to go. And even if it costs less to take care of per person chronic condition than, let's say, the standard, it's still going to be more than someone who's healthy. And so that prevents innovation or moving to scale. And so what I'm concerned about is we simply put a lid, because that's what we're doing. We're putting a lid, and we're not worrying about what's going on underneath that lid. And so what happens is that the quickest way for anyone to address this is to cut back workforce, drive out sicker patients, right? Make life more miserable for them, so they hopefully will leave your plan, hospital, whatever else, et cetera. And that's not going to lead to sustainable, and so that'll make things worse. So I think it's important not just to stick a lid. The question is, how do we incentivize and bring to scale pilot things that people have been doing for decades, actually. Interesting enough, one example of a pilot that didn't work actually was on the Medi-Cal side. I'm trying to remember, it was down in Southern California. Health system got a grant from Robert Wood Johnson, which to do, I think it was a 5-year pilot. They did all this, increased primary care, so et cetera, and ended up saving Medi-Cal a whole bunch of money. But the grant ran out. They went to Medi-Cal and says, well, can you keep paying for it so we can keep doing it because we're saving you a bunch of money? And this is before your watch, so it's not your fault, Mark, or anyone else. This is like decades ago, right?
I wouldn't have let that happen.
Yeah, you wouldn't let that happen. And they said, well, go back to Robert Wood Johnson. It's not our job to pay for it. Wait a minute. You're saving money, et cetera, right? Another example is that we had a group of NICUs, because I was involved in this, who did a quality improvement project that actually reduced expenditure from neonates, right? It actually shortened their length of stay, et cetera. Well, great. It made more, gave CCS, spent less money, but the hospitals didn't get any of it. And they actually put in money to make this thing happen. And basically the hospital administration said, great, we just spent, we all pitched in like, I don't know, $30,000 a piece to now lose money because there was no reward for continuing to do that from the payer. And you wonder why things don't go to scale. So so I realize our main task is to come up with a target, but that's why I'm so concerned about, like, we're not looking at things like risk adjustment and so forth, because what we could do is we could create a situation where basically the easy, quick way out is kick out the sick people and cut back the workforce and so forth, because that's how you get underneath the target. And if you can survive long enough and the other people go out of business who don't do that, then you're still the last one standing. And then, everyone else has to deal with you because there's no one else left to work with. And so I just want to be sure that we're not sticking a lid and creating a situation underneath that lid that basically is going to make things worse.
Elizabeth, you want to hopefully directly respond? Or
yeah, absolutely, because I think it's such an important point, and I can take no credit for it because the legislation was the core of the legislation was booked when I got here. But thanks to the wisdom of others, I mean, I think we're not just putting a lid, right? I mean, that under our performance measure branch, we are looking at primary care thresholds and APMs and behavioral health thresholds and equity and quality. So you know it well, but just a reminder for all of us that we really do have our own three-legged stool here under OCA. We know that consolidation is an important cost driver, so we're addressing that. We know that we do need to scale these successful pilots, and so we are creating incentives for those. So I just wanted to, I think it is an impressive body of work that it is looking at the performance side as well as the cost side.
But I am concerned that when we talk about, we don't do, and again, when we're talking about statewide, it doesn't matter as much. But when we started talking about enforcement and we're talking about we're not getting down to more individual entities and so forth, risk adjustment matters.
I know more comments, but throughout this conversation, I've been thinking about the piece of this that comes later, which are the sector targets. How do you see that overlaying, comments to the whole board, overlaying some of this? Because there are going to be opportunities, if you will, to apply the quote lid a little differently, or the tools under the lid, as you've identified in a slightly different way, to maybe lift up a piece where there's promising evidence that we all believe in and see flourish, as opposed to some other things, and maybe a place where costly technology ends up playing out a little bit more. The wisdom of the legislation, if you will, differentiated that work around sector targets, and I'd be curious to the staff kind of how you see that playing out.
Yeah, the thinking behind the sector targets was that a statewide one-size-fits-all, we needed to go beyond that. So sector targets allow for, to set a different target value. It could be, more higher or lower depending on the circumstances, but it could be for a geographic region, an individual healthcare entity, or fully integrated delivery system. Those are called out, and the board could, define the sectors broader than that. But the thinking is that it could be more tailored, where we could apply risk adjustment as well as equity adjustments, because it's more about the individual provider, payer, or it's far more tailored to the circumstances.
Okay. Can I have David go, and then Richard, and then I'm happy to look on this side.
Thank you. I'm probably jumping ahead, but I wanted to speak to the last slide here, which is the statement: the board has the authority to revisit the target, to update it periodically. I take a lot of comfort in that, because I don't think that we're necessarily going to hit the target exactly in the middle. In this first cycle of deliberations, there'll be adjustments that we'll want to make for a variety of reasons. In general, I think that the office's work here has been very excellent. I mean, it's very complex stuff we're dealing with, and I think that you've considered all the appropriate factors My only caveat is a statement about risk adjustment and, age, gender is probably where I'd land. But I think the fact that we can come back and revisit this, the context will change as we look at sectors and things like this. We're pretty close to probably where we want to be at this point.
Great, thanks. Clear point. Okay, Richard.
Yeah, and I appreciate the response from the staff. I guess and I know there's an overwhelming amount of work to do, but we focused in the past year a lot on the statewide target because that's our first task. Right. But I think it's important we also send clear signals, especially as we're approaching when we're about to approve potentially a recommendation. Let's put it this way: recommendations for 5 years, right, which includes years that will be enforced. And I think as we approach that time when we will finally adopt something that would include years that will be enforced, there should be indication on how that enforcement, the nature of that enforcement, and how the agency will be looking at things. So, for example, we've talked about risk adjustment. We've kind of rejected it for the statewide, but I think it's important that we send the signal that we are, we will take account of your risk profile if we end up, because what the last time we talked about, we said, oh, great, we're going to come up with a target when it's enforced, right? We are sector targets, all those things happen later. But so what's going to happen when we have a statewide target? Are we going to take that target and we're going to go to different entities and go, oh, you're above 3%, you're above, you're below, you're above, you're above, you're above, and now we're going to penalize you after the first year, right? So are we going? So exactly how are we going to apply this statewide target when it comes to individual entities who are all looking at, okay, how do we respond to this? Whether your health plan, your hospital, or health system, medical group, whatever else. I think we need to send some indications before when we're talking about enforcement of these targets, because they're going to look and say, okay, first year it's not, the second year it will be, and so how do I adjust my operations to respond? And what we don't want to do is get people, because they don't know what we're going to do, how the staff's going to do the enforcement, start behaving in dysfunctional ways that actually is harmful. So that's why I'm kind of urging that we think about in the path to our approval, because if we're really going to do 5 years, that we also start sending some indications about how we're going to, when it comes to enforcement, how we're going to be looking at things. Are we going to recognize when someone takes on a riskier population or not? Or are we just going to say, well, nope, you're above 3% and boom.
Yeah, I think it's a really important point, and one where, the legislation, well, the jump to sort of penalties or the harshest type of the enforcement is down the road. There is the conversation, the corrective action plan, the working together, the understanding some of it. And I don't want to, I think within that process, I would hope, and this is something we have to communicate, kind of what that looks like. And we can certainly prepare to do that. I am very mindful of time. I know to me, one of the most important parts of this conversation have been that initial set of feedback points of, I'm going to call it the staff homework, to come back to us and share some more refined, questions, answers to what we've done. Appreciate, David, your really sort of, hey, we could be pretty close here. There's a lot of different ways to slice and dice this, but, we're in the ballpark, and we take comfort in the fact that we can address some of these issues down the road. I'm going to do one last final round before we go to public comment. I'm not going to use burning, because that's not poorly defined burning question, but anything that people want to share before we invite the public to give us some. Okay. Yeah, go ahead, Elizabeth.
Very quickly,
yeah.
If you do that labor analysis that you talked about, could you please segment it by clinical staff versus administrative, and also do a macroeconomic analysis on impact on other sectors, on wages and job growth?
Wow, that was quick and a lot more complicated for you guys.
That's a lot, and we'll take it back to see if it's feasible.
Yeah, I think we obviously what's feasible and explain when it's not, and in order to get the rich resources that you need to do some of this, we will make sure you can get those people, avail yourself of them. Okay, just thank the board for all of that engagement and back and forth. Really appreciate it. We are scheduled to wrap up at 5. I know we want to make sure there's room for the public comment. I see in the room organizing. You want to take it away and help facilitate us through? Can I just ask one question? For the public comment in the room, is it possible to, instead of going back and forth, which I know we traditionally do, to have this, I think different folks probably building off each other, be great if we could just allow that to happen and then go to the virtual comments.
Yes, absolutely. So we are now opening up for public comment, both on the most recent agenda item and for general public comment. And as Secretary Galley mentioned, we'll take the members of the public that are here in the physical meeting space, and then we will turn to the raised hands virtually. And so we'll begin with this person at the podium. Welcome.
Thank you. Hi, I speak Spanish only. Mi nombre es Catalina Hernández. He trabajado en el Hyatt Regency en Monterrey durante 18 años, pero he sido recamarera en la península de Monterrey por 38 años. Hace 4 años mi esposo no se sentía bien. Los médicos estaban tratando de averiguar qué es lo que pasaba con él. Los médicos pensaban que era cáncer. Le hicieron muchos estudios. Después decidieron que le iban a hacer una cirugía en el hospital Choms de la península de Monterrey. Eso salió demasiado caro. La aseguranza, el seguro médico de nosotros pagó $185,000. Más nosotros tuvimos que pagar más de $20,000. Esos $20,000 los pagamos durante de 3 años más y más. Cada mes pagábamos $400. Eso me causó muchas dificultades de dinero, que no teníamos para comprar cosas básicas como comida. Tengo una familia numerosa. Tenía que eliminar ciertas cosas para comprar para nuestro hogar. Lo peor fue tuve que eliminar el mantenimiento de mi carro, que en ese tiempo se nos descompuso. No tenía dinero para componerlo, ni para comprar otro. Tenía que pedir raite para ir a mi trabajo y para moverme donde vivo. A veces no tenía raite, tenía que andar en el bus. Eso fue muy difícil para nosotros. La situación me causó problemas familiares. Me sentía muy frustrada. Cuando mi esposo necesitaba comprar su insulina debido que él usa insulina porque él es diabético, nos faltaba el dinero muchas veces. Recuerdo bien que eran de 2 a 3 meses que nos quedamos sin seguro médico y no pudo ponerse insulina porque no teníamos el dinero para comprarlo 100%. Pagamos de medicina cada mes entre mi esposo y yo por lo menos $300. En ese tiempo no los teníamos por andar pagando $400 por mes para el hospital, más lo de nuestra medicina para ambos. Nuestra área es extremadamente caro. La vida se nos redumbó por un tiempo. No ganamos lo suficiente para pagar un hospital, ni siquiera con 2 ingresos. Si los hospitales cobraran menos, todo sería muy diferente. Quiero pedirles que los hagan cobrar acuerdo de lo que nosotros ganemos. Hacer los hospitales que sean más razonables, porque cuando alguien cae a un hospital, dejan a la gente en la ruina y no tenemos para seguir viviendo. Les pedimos por favor que nos ayuden con los hospitales que no nos cobren tan caro. Gracias.
Thank you. We invite the next person up to the podium. Oh, yes, thank you.
Yes, please. Yes, please.
Thank you.
I will translate her story. Her name is Catalina Hernandez. She has worked at the Hyatt Regency Monterey for 18 years, but she has been a housekeeper in the Monterey Peninsula for 38 years. 4 years ago, her husband wasn't feeling good. The doctors were trying to figure out what was wrong with him. They did a lot of studies to him. They thought it was cancer. He had surgery in 2019 at Chomp Hospital. After the insurance paid around $185,000, they paid more than $20,000. It took more than 3 years to pay that money. They had to make an nourishment plan of $400 per month. It caused her family hardship because it was money that they didn't have to buy basic things such as food. She has a big family and they have to limit themselves when they used to do groceries. They limit their family from buying basic things for the house. The worst thing was that they had to limit the maintenance for her car. So it broke. They didn't have money to either fix it or get a new one. She had to ask people to give her a ride to work or to get around in town. When no one was available to give her a ride, she had to take the bus. This situation caused her family to have family problems. She used to be so frustrated when her husband needed to buy insulin because he's diabetic and they didn't have money. They paid more than $300 per medicine for both of them. The hospitals in our area are extremely expensive. They ruin people's life. They don't make enough money to pay for the hospitals, not even with 2 incomes. If hospitals charge less, everything will be so different. She wants to ask you to make them charge according to what people make. Make hospitals affordable, because if someone falls into the hospital, they leave people with no money to pay other basic things. Thank you.
Thank you.
We welcome up the next person to the podium. Thank you.
Hello, I'm Vicky Silva, and I've been working at the Hyatt Regency in Monterey as a supervisor for a little bit over 4 years. I have cancer and around $100K from the years 2021 to 2022, majority from Chomp. I went to Chomp 6 times, and they couldn't diagnose what I was wrong. I was going to be sent to a psychiatrist. It wasn't in my head. I sleep in my body every day. I knew there was changes. And I got tired of telling my primary doctor. I was sent to specialists, sent to everywhere. I got sick and tired. I felt defeated. I didn't know what to do. Finally, the last visit to Stanford, they found a lesion in my liver. My blood work came abnormal. They sent me to my GI. He sent me to Pacific Cancer Care. I think it was Thursday, and on Monday, immediately they started treatment on me. For a whole year, I did treatment twice a week, Monday and Friday. I was there for 4 hours to by myself because it was during COVID. So I had to go through that all alone. I was diagnosed with hereditary hemochromatosis, which I can't even pronounce, but I guess it's a blood disorder, and if it hits an organ, it becomes canceroma. I was sent to many specialists. I was in and out of the hospital. Sometimes I was there for 4 days, 3 days. I can't even keep track of the bills anymore. It gave me anxiety. It gave me depression. After a while, I thought I would have to go bankrupt, file for bankruptcy because I couldn't pay for them. Now I am currently the head of household for my family, my elderly mom and my 2 siblings. My other sibling was diagnosed with cancer 6 months ago, so he's out of work. His cancer is more aggressive than mine. And my cancer is not going to end a year from now, 2 years from now, 3 years. I'm going to have to do it for life. I did it for a year, twice a week. Now it's every 4 months. If my blood work comes back good, then I'll continue 4 months, but I'll do it till I pass away. So something has to change because eventually I'm going to end up at Chomp again. I have to pay right now the mortgage, water, and not only one water bill, it's the regular water bill, dirty water, and just for the chemicals that they put in the water. Garbage, electricity, phone, so my mom can get phone calls when we're in treatment or whatever, because I can't take anyone with me. I decided to ignore the bills because I couldn't pay them. I mean, they came from left, right, front, back. I had to make a decision. Do I want somewhere to live, my family for somewhere to live, or pay the bills? I need somewhere to live. First of all, I don't feel good. They tell me gain weight. How do you want me to gain weight when I can't buy the necessities I need for my house for a nutritious diet? Beans and rice, I'm thankful to have that, but that's not going to help me gain weight. And I'm 105 pounds right now. They tell me gain weight. Well, what do you want me to do? Gain weight by breathing air? I can't gain weight that way. Because Trump is so expensive, we lost our union raise that we were supposed to have September 26th, which could have helped me a lot. You know, that could have bought groceries for my home. Even if it wasn't the most luxurious groceries, maybe milk, eggs, cheese, fruit, vegetables. Anyway, I cannot afford the groceries that I need, and they can tell me to gain weight 1,000 times. I can't. With the diet that I have, I can't. I just can't. And now that we have 2 people in our household with cancer, my brother's is aggressive. Mine, I'll have to do till I pass away. And it's not something that a 49-year-old female wants to hear, but it's what I've been diagnosed with. I can't give it back. I have to do my treatments, and I have to think about it sometimes. Am I going to be able to go to treatment? Or do I want somewhere to live? That's my story.
Very much. Welcome to the podium.
Hi. I'm going to say it in Spanish, okay? Mi nombre es Sergio García. He sido cocinero en el Highlands Inn Carmel durante 23 años. En el 2004 mi pareja necesitó una cirugía. Ella no estaba en mi seguro porque aún no estábamos casados y no tenía ningún otro seguro. El costo total de la cirugía fue de 15,000. Teníamos planes de pago. Me pidieron que pagara 3,000 por adelantado y luego tenía un pago de $300 por mes. En ese entonces ganaba $13 la hora. Fue un momento difícil para nosotros porque estaba limitando los gastos de mi familia. Necesitamos hacer estos pagos. Estaba planeando comprar una casa, así que estaba cuidando mi crédito. Tenía mucho estrés porque estábamos recién casados y queríamos comprar una casa para nuestra nueva familia. Hubo muchos días que no pude dormir. Cuando pensé que por fin había terminado de pagar esa factura y que podía empezar a ahorrar para mi futura familia, recibimos una nueva factura de $1,200 por la anestesia. Los precios de los hospitales no son justos en absoluto. Los cuidadores del hospital se esforzaron mucho en cuidarnos, pero ¿cómo íbamos a sobrevivir esos precios? Quiero pedirle a este comité, por favor, nos ayude a que los hospitales dejen de aumentar sus precios y que bajen sus precios para que sean justos y algo que las familias trabajadoras como la mía pueda pagar. No puedo imaginarme yendo al hospital en este momento, con o sin seguro. Este año, mis compañeros del trabajo y yo no tuvimos ningún aumento salarial en mi trabajo porque lo negociamos como aumentos, se destinó a pagar la atención médica. Sin ese aumento, comencé a usar el dinero de mi cuenta de ahorros de emergencia para poder comprar artículos básicos para mi casa. Me preocupa si tuviera una emergencia, como si mi auto se descompone o si yo o alguno de mis familiares terminamos en el hospital. ¿Qué voy a hacer?
I will translate Sergio's story. His name is Sergio Garcia. He has been a cook at the Highlands Inn Carmel for 23 years. Back in 2004, her partner needed a surgery. She wasn't on his insurance because they were not married yet, and she didn't have any other insurance. The total cost of the surgery in 2004 was $15,000. They had payment plans. They asked him to pay $3,000 upfront, and then they have payments of $300 per month. Back then, he was making $13 per hour. It was difficult times for them because they were limiting their family spending. They needed to make those payments, and they were planning to buy a house, so they were taking care of his credit. He had so much stress because they were newly married, and they wanted to buy a house for their new family. There were many days that he could not sleep. When he thought that he finally finished paying that bill and could begin saving for his future family, they received a new bill for $1,200 for the anesthesia. The hospital prices are not fair at all. The caregivers at the hospital put a lot of effort into taking care of them, but how could we survive those prices? I want to ask this committee to please help us to have the hospitals stop increasing their prices and to lower their prices so that they are fair and something that working families like mine can afford. I can imagine going to the hospitals right now with or without insurance. This year, my coworkers and I got no wage increase at my job because what we negotiated as raises went to pay the healthcare increases. Without that raise, I started using money from my emergency savings accounts to buy basic items for my house. I am worried that if I have an emergency, like if my car breaks down or if I have any of my family, if I or any of my family members end up in the hospitals, what will I do?
Much. I invite you to the podium.
Thank you. My name is Esteban Rodriguez. I work at Monterey Ties as a bartender server. Been there for 4 years. I'm also a coordinator for the nonprofit organization called Building Healthy Communities. I'm coordinator there to help underserved communities. I've been there since 2021. So I've had an expensive medical bill in 2020 that the total was about over $167,000, which I had to pay over $5,000, and I ended up paying it in over 2 years. I actually have proof of it. I don't know if I could share that with you guys, but I brought the bill with me. If you don't mind, if I could start with you. So as you see in the top portion, that's the total of the medical bill, and then the bottom is my payment plan that took me 2 years to pay. The expensive medical bill that I had to pay did cause me hardships. I ended up having another job, which is the coordinator for the nonprofit, in order to pay back the medical bill plan. Because I just didn't want to go into collections if I wasn't able to pay for the medical bill. Since I'm a single parent, this dramatically forced me to change my lifestyle by not being able to see my kids as much. I used to see them about 3 or 4, days out of the week, which that turned down to like 2, maybe even 1 night out of the week, and that was really hard. I had also changed my budget by not spending so much on groceries because I was always trying to make ends meet. I started to go to the food banks to get food, and that was the way I was getting food and provide groceries for my children and for myself. That caused me major stress. It was just another bill on top of the other bills that I had to make sure that got paid. I had to pay rent, utilities, car insurance, and so forth. And sometimes I prioritize those things before I could buy groceries myself, or provide groceries and provide food for my family, which was really tough for me. I don't think that hospitals and medical bills are expensive. I know they are because I experienced it and lived through it. I can't even imagine how it would have been if I didn't have some sort of health insurance. I'm very thankful for that, and being, working at a union place, that definitely helped a lot. Neither the hospital, the doctors gave me a heads up of how much things would cost, or else if I would have known ahead of time, I unfortunately probably would have declined many medications or treatments just to keep the cost low, which risking my life or well-being overall, so I could just keep that payment lower. To suggest choosing a cheaper hospital just sounds awful and feels wrong. Everyone deserves quality healthcare without financial strain, just as access to affordable housing should be a fundamental right for all. A few things I would like to for this commission to consider is to emphasize the crucial need to accessible and affordable healthcare for all community members, advocate for policies and initiatives that prioritize healthcare as a fundamental right, ensuring fair and equitable access to quality medical services without financial barriers or strain. I also like to stress the importance of employers prioritizing their workers' health and well-being as much as they prioritize the profits and shareholder satisfaction. By holding employers accountable for employee well-being and healthcare, it can pave the way for more affordable and reasonable healthcare prices. The accountability would ensure that healthcare becomes a priority, leading to a more accessible and fair healthcare options for everyone within our community. Thank you for your time.
Hello, everyone. My name is Celica Valdez. I am an organizer with Unite Here Local 483. Now is Local 19. I am a former housekeeper. I work at the Hyatt Regency in Monterey for 6 years. Last couple of years, it has been very difficult for our union. Since the pandemic, we were concerned for the benefits of our health insurance. We have done a lot of mobilization with our membership. However, no matter what we do, will never be enough if the hospitals continue to raise their prices. Last August, our members and many of our members didn't receive a wage increase that were negotiated during our last contracts. It was heartbreaking, the stress that it caused to many of them. I saw in their faces their concerns, their anger, and their disappointment for this issue. They fear that they will not have enough money to pay their rents, their utilities, their food, or their basic things to live. I have heard so many heartbroken stories of how high cost of hospitals affect the lives of people in my community. Personally, I have been in the hospital 3 times in my life, luckily, only when I was having my daughters. I have 3 daughters. 2 of my daughters were born in Berkeley, in Alta Base. My youngest daughter was born at Natividad Medical Center in 2020. So I was in Natividad Medical Center because I was told that it was the cheapest hospital in the Monterey area from the 3 back in 2020. In the room that I was, it was 2 families in December of 2020, where the COVID pandemic was really high. So I have a lot of concerns because of that. But however, I was shocked when I started receiving the bills of how much my insurance paid for my pregnancy or my delivery in the hospital. I saw bills of $40,000, $20,000, $2,000. I lost track of how many bills I got. Luckily, I was able to get medical during my pregnancy, so I didn't have to pay. But I saw those prices, and it was really shocked because in Alta Base, I have 1 room for my whole family, for my 2 oldest daughters, and in Natividad, it was a shared room that I didn't mind. I was okay because I was getting a good service from the nurses and from the doctors. But seeing those bills and how much my insurance paid, and how right now seeing how those bills are affecting our memberships in my community is really heartbreaking. Our health benefits are at risk. I don't know what will I do if I will have no insurance. Please do something to control the prices of the hospitals in Monterey County. Thank you.
Thank you.
Let's switch to virtual and then come back to the room.
Okay, so turning over to virtual members of the public, we have Steve McGoogle at the top of the queue. We invite you to unmute.
Members of the board, good afternoon. Representing the CFT, a union of classified professionals and educators. We, along with a coalition of labor, generally support the OCA staff recommendations, but we wish the growth target was even lower because of the lack of affordability today, and in particular in Monterey County, and in particular, the community hospital of the Monterey Peninsula. Nice try. Stand by for future public comment in a few minutes. Yes, we strongly support median income as the basis for the spending target, but it comes closer to capturing, because it becomes closer to capturing what Californians can afford than the wealth of the economy. We also support no phase-in of these regulations beyond what is already built into law. and support that recommendation. People are hurting now and have been for years. There are no other cheaper hospitals in Monterey County. You gotta cross the county line to find something cheaper. We're on to you. Hopefully the OCA board, the Healthcare Affordability Board, and anybody else that's listening out there is on to you too, Monterey County hospital providers, including the community hospital of the Monterey Peninsula. Happy holidays, everyone. Thank you for your time. See you again in the new year.
Thank you. Now turning back to the physical room here.
Beth Capel on behalf of Health Access California. Our North Star has been consumer affordability, and it's in part because of stories like the one you just heard. We would also add that at the advisory committee meeting, even with Unite Here Health, shared that the community hospital of the Monterey Peninsula is now charging 559% of Medicare. The Unite Here Health Trust Fund from across the country is cross-subsidizing the workers you just heard, and you still heard what horrific costs they're facing out of pocket. We wish the recommendation were stronger. We understand the constraints of the law and the constraints of assuring that people are actually getting care. We are pleased that there's no phase-in. You've all had a lot of conversation today, but the people who just spoke are so much more eloquent than I can be. I can talk about the economy going down, incomes going down into the Great Recession while premiums kept going up. You've already talked about that. I can talk about 3% meaning that things don't get worse, but things are bad already. The lack of affordability is causing real harm. People avoid care, they delay care. That's what we're struggling with as we struggle with these recommendations. You've already heard a few examples of things that can be done to improve care while reducing costs. We're going to provide you a longer list, but obvious things: reducing readmissions, reducing hospital-acquired infections, improving maternal mortality and equity in maternal care, reducing emergency room visits for ambulatory sensitive conditions. These are all things that some parts of the healthcare system have done and that more can be done on. The OCA law, and at 9 a.m. tomorrow morning, Dr. Pan, we're going to have a primary care work group where we're going to discuss the standards for primary care. That was built into the law, and that opportunity presents itself in not very many hours for some of us to talk about primary care. And we've already had a lot of discussion about alternative payment models and behavioral health to come, because we built that in to the vision of improving the quality of care while reducing the costs. Two other more technical points. My understanding is that both Oregon and Washington use a 20-year look back in terms of their data, because 10 years yields too much fluctuation. And additionally, numbers I've seen run in recent days indicate that if we added 2022 median income, we would end up at 3.0. So there we are. We are, as I say, generally supportive of the staff recommendation, but we do wish it was stronger. Thank you.
Thank you. Now turning to our members of the public who are here virtually. Pamela Swint, we invite you to unmute. Pamela, you're still muted on our end. Are you able to unmute on yours? You're still muted. Sorry, Pamela, you appear to be muted on your end. So we will move on to the next person. Katie, we invite you to unmute.
Am I unmuted?
You are. Please go ahead. Yes.
Good afternoon. My name is Katie Bassler, and I live in Monterey County. I represent over 1,000 educators, specifically in Salinas and in Monterey. I would like to first honor the speakers who came in person, as their voices and stories are true, heart-wrenching, and are a reality of our healthcare environment in Monterey County. What I'd like to speak on is to bring to your attention the response of the Community Hospital of Monterey Peninsula, CHOMP, after an article was published in a local newspaper that exposed the ending year additional balance of the 3 local hospitals. CHOMP had an additional 90 million. So as these honorable folks were billed thousands of dollars and their lives changed, the hospital actually increased its reserve. In response to this article, the CFO of CHOMP published a 3-page response to the local newspaper defending their finances and business practices. It's an incredible read of their narrative that it was incredible to read. And then magically, last Friday, CHOMP announced that the hospital system would be canceling 100% of all debt owed by patients from years 2020 to years 2022. After hearing the speakers today, I can only hope they will be included, though they've already toiled to pay their bills. But I have no trust in the practices of these 3 hospitals. They are predatory and have gone unchecked for years. I don't know if CHOMP's cancellation is causational to the article or just a coincidence, but nonetheless, in my heart, I know that their published article is to save their image. CHOMP is a private-like hospital, and the name is misnomer. They do not care about their community. In their article that they stated cancellation, they mentioned the job classes of the exact public speakers you are hearing today: hospitality workers, agricultural workers, and educators. We aren't done fighting in Monterey County for accessibility, affordability, and continued quality healthcare. In closing, you can see we need Monterey County because of the healthcare systems controlled by these 3 hospitals that have drivers to unaffordable rates. We need this board to consider making Monterey County a different region or sector. It doesn't fit into any other area. I appreciate all of the work. Today's dialogue was sometimes above my head and other times so informative, and I appreciate all of your work. Thank you.
Thank you. Turning still virtually now to Christopher Ruggles. We invite you to unmute.
Can you hear me?
Yes, please go ahead.
Thank you, members of the board. Christopher Ruggles speaking on behalf of AFSCME California. We generally support the recommendation of the board. We believe that a more aggressive approach is needed to address the soaring cost of healthcare. Union members over the years have taken concessions at the bargaining table just to be able to afford healthcare for themselves and their families. Lower healthcare spending targets allow for our members to negotiate for better wages and improved working conditions without compromising on their healthcare benefits. The high cost of healthcare is a crisis. We need to slow the cost of growth so that healthcare is more affordable for everyone. We agree with the recommendation that there will be no phase-in of these recommendations beyond what is already built into the law. We look forward to continue working with you. Thank you for all the board has done so far, and thank you for your time.
Thank you. Now we'll invite someone here in the room to the podium.
Hi there, Ben Johnson from the California Hospital Association. We share the goal of creating a high-value healthcare system and affordable care for patients. However, we are concerned that the proposed target would be unattainable, unsustainable, and really unsupportive of the changes that need to be made to realize savings that don't come at the expense of access, quality, and equity. Just like to first put the target level that's been proposed in context with some comparisons. First, we find the proposed target is 20% lower than what was initially proposed or implemented, excuse me, in Massachusetts. And moreover, Massachusetts targets were set at a time when inflation in the general economy was at historic lows, unlike the 4 to 6% inflation currently hitting the U.S. and California economies. In fact, the target is about 20% lower than the multi-year projected inflation that the LAO says is going to be going forward in the coming years. And it's also actually lower than the multi-year average target in all the other states that were reviewed in the slide, which generally put their targets a few percentage points above their historic levels of GDP growth, as shown in the CHCF report on affordability and this program, whereas California's would be about half the rate of GDP growth that the state has been experiencing in recent years. Similarly, when you look at peer countries that have model healthcare systems that we would like to really aspire to, they have growth rates in per capita healthcare expenditures that are about double what is being proposed by the office. Further, we are concerned that it doesn't account for demographic changes in California, like aging and chronic disease. And we are concerned that these adjustments are, in fact, quite a bit larger, or really, I should say, these effects are quite a bit larger than what OCA has estimated. In fact, by combining just two public data sets, which we think are authoritative on this subject, CMS's actuarial national health expenditures data broken down by age group, reference and similar data set to what Mr. Pagani referenced earlier, and the Department of Finance's projections of population, we find that healthcare spending alone from this impact would increase by 0.7% on an annual basis. This is about 6 times the one decimal point estimate that has been put forward by the office. We're also concerned that it doesn't account for the technology costs that were discussed significantly earlier today. For example, we looked at CMS projections of pharmacy costs. Pharmacy is generally not a regulated entity by the office, and these are projected to grow 25% higher than this proposed target. So we have various concerns with this level and concerns that it's going to create undue harm for patients in California, and ultimately not be supportive of healthcare entities to improve the value of the care that they provide. We urge the office to adopt reasonable adjustments for vulnerable populations, as state law clearly intends, for policy changes such as minimum wage, which is going to increase costs significantly over the coming years, and for current inflation levels, which are projected to be above the actual target that is being considered. Otherwise, healthcare entities will face hard choices around shedding costs in faster, easier ways, potentially regardless of longer-term impacts on really the things that we want to create in this healthcare system. So appreciate that. We are doing analysis similar to what a board member has suggested around potential impacts on healthcare workforce. Do think this is an important matter for the office to look into, and look forward to continued engagement. Thank you.
Thank you. Now turning to virtual hands that are raised. Harvey, we invite you to unmute.
Hello, can you hear me?
Yes, we can hear you.
Okay. So, my name is Harvey McKeown. I'm from the Carpenters Union in Northern California. I'd like to express my admiration for the brave testimonies at the top of this comment section. Secondly, to get to the point, unhinged rises in healthcare costs is intensifying our ongoing fight and mission to represent and lift up the working class, including the workers in the 11 construction trades we represent. We're proud to offer our members healthcare, but healthcare costs are often one of the cost factors influencing a contractor's status as union or not. The more they rise, the less the playing field is level between responsible and not responsible employers. Currently, it's estimated that roughly a quarter of California construction workers lack health insurance versus around 10% of all California workers. So our ability to represent and open our union to all workers is directly impacted by unchecked and opaque decisions of organizations such as our own main provider, Kaiser Permanente. We're currently using existing regulatory mechanisms to try and understand more why extortionate rate hikes in the large group market are being proposed this year. But in the meantime, we do generally support the OCA staff recommendations on this item. That said, we wish the growth target was even lower because of a lack of affordability today, and we support no phase-in beyond 2028. We needed this enforcement yesterday, really. And I'd also like to caution out, to react to some of the discussion today, this notion that smoothing out life-changing economic turbulence, like the financial crisis, the pandemic, is somehow logical. But before that, you even had the dot-com bubble specific to California. These things happened, and to pretend like they didn't is like pretending GDP growth is somehow relevant to people's everyday lives. So I look forward to the continued discussion. Thank you for taking my comments.
Thank you. Virtually again, Pam Swint, thanks for trying again. We invite you to unmute.
Become disabled. I went
Pam,
from.
we do hear you. Please go up. If you could begin, thank you.
Yes. Hi, my name is Pam Swint, and I'm 44 years old, and I've recently become disabled. I went from running a half marathon in 2018 to buying a wheelchair van last October. I was diagnosed with a primary progressive multiple sclerosis, an incurable lifelong neurodegenerative disease in February 2020. I'm married and a mom to a 12 and 14-year-old. MS is an expensive disease. I choose to participate in a clinical trial in part to have a sort of vacation from paying and worrying about insurance for treatment, neurologist appointments, and MRIs. Excuse me. Although we're fortunate that we're able to cover expenses, I have 2 kids on the horizon of entering college, which would be a considerable expense. I really had no idea how expensive disability was until it happened to me. I use a variety of mobility devices, forearm crutch, a rollator, scooter, and power chair. The 2017 Toyota Sienna wheelchair conversion van I bought recently was $64,000. Renovations to our kitchen and bathroom for accessibility cost $130,000. There's only one FDA-approved medication for my type of MS called Ocrevus, with a sticker price of $120,000 before insurance negotiations. Twice yearly MRIs for brain, cervical, and thoracic spine cost about $10,000. Doctor's visits for neurologists, neuroophthalmologists, physical therapy, occupational therapy cost about $400 each. I just had a surgical implant for a neuromodulator to help with bathroom issues, and that cost $2,400 out of pocket. I'm sorry, that's hard to hear me. We're very fortunate that my husband has a good job with great insurance. Our yearly income is about $200,000. We have a high deductible insurance plan of $3,000 with an out-of-pocket maximum of $6,000, of which I have still $1,400 to go. Our monthly premiums are $700 out of pocket, with my husband's employer paying the other $700. Durable medical equipment is covered at 50% once the deductible has been met. The $5,000 power chair I chose was not covered by insurance and was considered a luxury device. Again, thank you for your time. I'm sorry it was hard to hear me. Because of rising healthcare costs, I hope that the board uses an even lower growth target based on median income with no additional phase-in of these regulations, because people like me are hurting and we can't wait for the system to continue to get worse.
Thank you so much for your testimony. Are there any other members of the public in the room here who would like to come to the podium to speak? And looking virtually at members of the public, there are no raised hands at this time. So Secretary Galley, I'll turn it back to you.
Well, without responding specifically to every last public comment, I just want to, I think on behalf of the board, share a deep appreciation for both the virtual testimony, those who traveled here at no small expense to share their own personal stories, and it both puts a face and a voice with the object of why we're here. I think today's discussion was rich. We heard calls for being stronger and firmer, and others suggesting a different approach. I think we gave our team at HCI and OCA quite a bit to think about, come back to us with alternatives and suggestions. I know this isn't easy work, but I think getting it as right as we can. David acknowledged that it's not going to be perfect and we're going to get chances to redo it. I think it's really important that we keep taking these steps, and I appreciate everybody pushing us to get to a place that honors California's sort of tenacity and ability to do this kind of work right. It's moments like this that I feel very privileged to be at the table with all of you, thinking about this, taking it as serious as the stories that we heard today. I will just say, I know it's not signed on the dotted line yet, but this idea that a frequent theme here is this unique situation in Monterey. I don't want to say it's unique, but we learn about it at these meetings. We hear about it through different pieces, and this show should get on the road once in a while, and maybe a visit there in the first quarter of next year, and having a meeting there with an opportunity to engage more locally, I think will be important. So something I know the team is working on, but just a preview as we wrap up this year, and a lot of gratitude to all of you for your sacrifices. Looking forward to maybe digging into this question on Monterey a little bit more specifically and down the road. All right, with that, happy holidays, just gratitude again to the staff, to the members of our board, and then to the public and all the consultants who help us get to these rich conversations. Thanks, and take good care.